Welcome to this very special Gairdner Global Perspective panel on the Sustainable Development Goals and global health through the pandemic lens. I'm Janet Rossand, and I'm President and Scientific Director of the Gairdner Foundation. The Gairdner Foundation is based in Canada and gives out every year Canada Gairdner International Awards to celebrate excellence in health research that has impact on human health. To give you an idea of the impact and the influence and the prestige of these awards, since 1957, we have awarded over 395 awards have been given out, and 95 of those have gone on to receive a Nobel Prize, including 3 of this year's Nobel Prize awardees. One of the very special awards in our set of awards is the John Dirks Global Health Canada Gairdner Award, which specifically recognizes research with impact on global health issues. And this particular panel and discussion is really a celebration of that award. This event is actually part of the Gairdner Week celebrations, where all our laureates, the 2020 laureates, travel across Canada, lecturing at universities and high schools, and translating for the next generation of science, the excitement of science and the excitement of research. We're really reaching out to the next generation. Of course, they're not actually traveling across the country. This year, their travels are virtual, but we've already had some very great events across the country. Today's event features this year's Global Health awardees, Quarraisha and Salim Abdool Karim, plus a great list of speakers and panel discussants who are going to engage us in a wonderful and important debate around global health issues. A few thank yous, particular thank yous to our sponsors, the International Development Research Centre, IDRC, Grand Challenges Canada, the Dalai Lama School of Public Health, the Centre for Global Health there, and the Sick Kids Centre for Global Health. And a very special thank you to Sarah Devonshire, who is Senior Project Manager here at the Gairdner Foundation, for all her work in really pulling together this panel and the logistics behind it. So without further ado, I'm going to hand you over to our hosts for today's discussions. Montasa Kamal, who is Program Leader, Maternal and Child Health at IDRC, and Carly Silva, Co-CEO of Grand Challenges Canada. Thank you.
Thank you very much. Thank you very much, Janet, and it's my pleasure to welcome you all here. We're honored to be your co-hosts here today for the Gairdner Global Health Symposium. For many years, the global health community has been saying that health and health-related sustainable development goals should be central to all future health and social policies and plans. Now is the day in this symposium where we will hear more about why the current pandemic makes this all the more urgent and timely. This symposium has keynotes by 6 extraordinary leaders and scientists who are applying decades of experience to guide their nations through the pandemic. Carly, now over to you.
Thank you, Montasser. We're very fortunate as well to have several other bold thinkers joining our keynote speakers as panelists to bring a diversity of perspectives to understanding where we are with the Sustainable Development Goals and how the current experience of the pandemic should change our collective approach going forward. We promise it will be worth another few hours of your life in front of Zoom.
Thanks so much, Carly. I just want to share that I'm particularly excited today to hear about the experiences from different corners of the globe. If there is one thing the pandemic taught us, it is that humanity's coexistence is predicated on the decisions and actions made by each one of us, each individual, country, government, and region. What the leaders from the global health community will say here today will hopefully help bring scientific communities closer to reaffirm this message and to chart a way forward. Carly?
Absolutely. And I'm looking forward to hearing how the next generation of approaches to achieving the Sustainable Development Goals are themselves more sustainable and resilient because of this experience we're collectively living through. So without further ado, let's bring on our first speaker. Dr. Zulfiqar Bhutta likely needs no introduction, but for the few who've never had the pleasure to meet him or be exposed to his work, go back to the last meta-analysis you read on maternal, newborn, child, and adolescent health, and it was likely written by him. He's a master of synthesis and is going to set the stage today by providing his thoughts on the first 5 years of action towards health and health-related sustainable development goals. Zulfi, over to you.
Thank you very much, Carly and Montasser. And you know, I'm delighted to be able to open the innings for this fantastic symposium. It takes me back to my high school days when I would be often sent in to open the cricket innings. And with quaking knees, I would plead with the captain. He would tell me what a great honor it was. And I could never figure out if it was a great honor or being led to the slaughterhouse. So nevertheless, I'm delighted, thrilled to be here in a symposium as exalted as this. To understand the Sustainable Development Goals, one needs to start with the Millennium Goals. And I hope I can move the slides. And the Millennium Goals, ladies and gentlemen, are the goals that guided global policy in terms of reduction in poverty and a lot of health-related indicators. Between the years 2000 and 2015, they were signed by 183 countries of the world in the year 2000. And of the various MDGs, the ones that people recall most are the ones that were related to reduction in child mortality and maternal mortality. And they were the bellwether, more or less, for the MDGs. Many don't even remember the numbers of the other MDGs that we had there, but never really got to, particularly things like gender equality or reducing hunger. We eliminated poverty perhaps by just using some World Bank criteria, but never got to the nuts and bolts of this. But the achievements in child and maternal mortality reduction were stellar. And if you look at the annual rate of reduction of, for example, child mortality and maternal mortality, we achieved 3 to 4% reduction annually. The neonatal mortality stayed a little slower, but still they were able to reduce from 10 million child deaths worldwide under 5 in the year 2000 to less than 5 million deaths by the time the MDGs closed. But by the time the MDGs got to 2015, it was apparent that these 8 MDGs did not capture the entirety of where the world wanted to go. And the transition to the more ambitious 17 Sustainable Development Goals was a deliberate, thoughtful, and involved process. These 17 SDGs are the future direction of where the world needs to go till 2030. And it's amazing that 5 years have already passed. They are the core principles that are based on universality, the importance of integration, and they were supposed to be transformative. And they were negotiated over a 2 year period at the United Nations with an enormous amount of engagement by civic society, by governments, by academics, and health professionals. So the one thing that did not happen with the MDGs, which is broad global engagement, actually happened with the SDGs. These SDGs are different from the Millennium Goals in several ways, and I'll try and summarize that in a single slide. So instead of traditional assistance, we are talking about universal principles. They are more comprehensive. They have included an inclusive process of goal setting, and they also make the distinction between hunger and poverty, which we never did in the MDGs. So the poverty alleviation goal is separate from that related to food systems and eliminating hunger. Instead of just looking at quantitative gains in education, we are looking at quality as well. And the focus is much more on domestic resources, on people becoming self-sustaining, hence the principles of the SDGs. So let's have a quick look at what the SDGs are. These 17 SDGs include a number of things that I will go through in detail, but just to point out that of these, around 10 are health and health-related SDGs, and they are broadly looked upon as indicators in relation to health and health-relevant outcomes by global organizations and countries. The first SDG is on poverty alleviation. And it's important to recognize that as we speak, a lot of the world's countries are not on track. And you can look at that by a map of the share of the global population living in extreme poverty, less than $1.90 a day. And you can see it's the same geographies where we have had lack of progress in many of the health indicators as well. Hunger and food security, a very specific target for the SDGs. And you recognize that two regions of the world, South Asia and Sub-Saharan Africa, account for almost 2/3 of the world's undernourished populations. And you see this quite clearly in this map, and I'll say a little bit more about one manifestation of undernutrition in the form of childhood stunting shortly. We also have the very broad Sustainable Development Goal 3 of ensuring healthy lives and promotion of well-being, which takes a bigger dimension and a measure of health than mortality alone. And there are a number of indicators on which some have seen progress like child mortality, but recognize that we still have close to around 5 million deaths of children worldwide. Life expectancy varies in many parts of the world, and it is one of the reasons why you are seeing enormous differentials in mortality in relation to COVID-19 is because many countries have different population pyramids, and therefore very few people above the age of 65 or 70 years of age where the mortality itself peaks. Education, as I mentioned, the focus is on quality, but we also recognize over the last year, just in South Asia alone, the region where I've looked at this closely, 430 million children have been out of school since the beginning of this pandemic in March, and many still have not been able to get back. So even if you stepped away from COVID-19, the quality is a big issue. And if you look at a global map of the share of students in primary education who have achieved some level of minimum reading proficiency, large parts of the world, particularly regions where we work, are actually blank because very few there have the quality education that we are talking about. Gender equality was there in the MDGs, was there in a token form because nothing really much was achieved. And there are many measures of this, and some of those measures are soft. So we don't have a lot of data in terms of looking at this quantitatively and objectively across the world. But some of the information that we have is extremely alarming. And one such measure is the experience of violence, intimate partner violence within a domestic situation. And you can see where many countries stand in Asia and Africa and parts of Latin America. Water sanitation, we appear to have made enormous progress of that in the MDGs, but when you drill down and look beyond the numbers and what may be regarded as improved water, a large proportion of what is improved water may actually still be unsafe. And you can get a sense of the disconnect between water coverage data and sanitation just by the relative shapes of the maps. So the world still needs to make tremendous progress in terms of achieving appropriate sanitation and eliminating open defecation in many parts of the world that still accounts for about 20–30% of the population. I have talked about inequality, and I will come back to it in some detail, but there are many measures of those. And one of those that is one of my favorites is the proportion of developing countries who participate in international organizations. And the important take-home message here is that about a quarter of all LMICs have actually zero participation in many of these global bodies, including the finance corporations, IBRDs, monetary fund. People who have the money hardly have any participation from people who need it. And that's one of the differences in terms of being able to regulate yourself as things go on. But there are wide disparities, not just in income, expected years of schooling, life expectancy, and mortality, which are largely recognized between countries. And as we look at this in greater detail, some of these differences are actually also there within countries. Making our cities safe, one important health and health-related SDGs, 1 of 4 urban residents live in slum-like situations. And if you just look at the proportion of those populations in various parts of the world, these have unique challenges. And some of those challenges were a major worry at the time when the COVID-19 pandemic hit us, because these populations have no means, no mechanisms, no ability to self-isolate or quarantine. Climate change, we've heard a lot about climate change and its impact on health, and I hope the world will change. And one day the world will realize that some of the environmental degradation and climate change was behind what we have encountered this year as a historic pandemic of the last century. And one measure of that, and it's only one of several measures, is how many people have been displaced because of natural disasters. And in the region where I come from, South Asia, this year has been particularly bad with massive floods, anticipated and unanticipated, that have displaced populations in both rural and urban settings. The slides have given up on me, so maybe someone can help me there. So if you can move to the next slide. You would recognize that one remaining SDG that I talked about was on peaceful existence and inclusive societies. And here there are no good measures that we have on a global platform. And one such measure that I've often talked about is countries that have to live in conflict zones and in insecure settings. And you can see again, there's the preponderance of that in Africa, North Africa, Middle East, and parts of South Asia. So each one of these 17 SDGs is extremely important, but they're not disparate because they are interrelated and they are connected. And that's the most important thing to recognize as we move forward in the SDG period in the last decade. So I want to focus on a few things. And in the interest of time, I'll focus on just a couple. So it was Martin Luther King who highlighted that inequality in healthcare was one of the most shocking and inhumane forms of inequality. And nowhere in the matrix that we have is the stark contrast as evident as in the global disparities in maternal and newborn survival. So if you look at some of these ratios of the close to 400,000 maternal deaths that still take place worldwide, the vast majority are in Africa and South Asia in a limited region. And if you were to overlay on that the map of newborn mortality, not very surprisingly, the 2.4 million newborns who die every year are also clustered in the same geographies. We also recognize that there are differences between countries that we measure through differences in coverage rates. This is the way that we have been traditionally doing this over the last 15 years in Countdown, is to look at differences in coverage of essential interventions across the continuum of maternal and child health. Each one of these dots represents a country. And as you can see clearly, for many of these interventions ranging from pregnancy, childbirth, and early newborn period, many countries hardly achieve close to 40–50% median coverage. And some are way, way, way below it. But the real differentials are within countries. And you can see this through a measure which in this particular slide is at a regional level through asset or income deciles. And when you look at this, for a variety of interventions that are captured in the composite coverage index, it is the bottom two deciles, the poorest 20%, who are way off in a different sphere than the relatively rich or those who are clustered in the middle. So it's the poorest of the poor who actually fall through the cracks in many of these aspects. And since I mentioned newborn survival, I will show you again the differentials between under 5 mortality and newborn mortality. So look at the bottom of the slide, which will have differentials by the income quintiles by under 5 mortality, and much lower mortality amongst the relatively rich compared to those who are in the poorest quintiles at the top. But look at newborn mortality, it appears to be clustered together. And one of the reasons for that is that even amongst the relatively well-off, quality of care for newborns in many low-middle income countries summarized here was extremely low and ignored in the Millennium Goals period. There are other measures of measuring inequality that we are just beginning to grapple with, and one of those is ethnicity. So this is a graph that Cesar Victoria drew for me recently, where we've looked at the difference between the dominant ethnic group in a given country and the rest. And you can pick any country here. The red circles are the dominant ethnic groups. And on the x-axis is neonatal mortality rate. And it doesn't take a rocket scientist to work out that even though you may not have huge differences on averages, but some of these ethnic minorities in countries are way off target. And this may not only be on the basis of poverty. This is on the basis of social exclusion. This is on the basis of marginalization, and can be related to many factors that we recognize in this country as the basis for inequality. So we are beginning to get to grips with this, and the SDGs offer an enormous opportunity for looking at this differently. Why should I speak to you about sustainable development goals and their relevance in an integrated manner? Perhaps the best example that I can give you is that of childhood stunting. So stunting, still prevalent around 148 million children worldwide, are below what would be an acceptable standard for their height for age. And we look at these who are below the 2 Z scores, -2 Z scores, as being at greatest risk of adverse outcomes. Some of those adverse outcomes, you can get to the next slide, please, are listed here on the slide. And they may relate to both in loss of income, loss of potential in terms of human capital. Could you move to the next slide, please? And also excess risk of mortality. And those are well recognized in stunted children as major risks for adverse outcomes. Could we have the next slide, please? So we recently looked at this in terms of global geography. Move on to the next slide, please. And I'm sorry, I'm doing my best, but I need to move the slides. And these 5 countries that we looked at are countries that were recognized as stunting exemplars, countries that had made exemplary progress in reducing stunting over and beyond their average GDP gain over this period of time. And these 5 countries that I've mentioned here offered an opportunity for us to look at how stunting reduced and through what particular interventions. This has all been published recently, and I want to take the example of Peru. So if you take Peru, it's made an enormous progress in reducing stunting over a relatively short period of time, not just nationally on average, but also within regions. So the Cusco region that you see at the bottom are where many of the high mountains are. And you can see between 2000 and 2016, overall, as well as by regions, there was an enormous reduction in stunting to the order of about 3% average rate of reduction. We analyzed this by looking at what had contributed to this, by looking at what is called Victoria scores, height for age Z distribution over time. And what you begin to see very clearly is that over this period between 2000 and 2016, the whole growth curve of these children shifted. So not only were they starting off a little better in their early months of life, but also their depreciation after 6 months of age reduced. And that could be related to better nutrition and also better disease management. What contributed to this? We looked at in greater detail through what is called decomposition analysis. And it was contributed by a number of factors highlighted here: improved health services, improved household food security, increased income resources, and a social safety net, and many other contextual enablers at the country level. In the bottom band are the various contributors to reduction of stunting in Peru. And if you drill down as to what they are actually all your SDGs. So nutrition, of course, SDG 2 contributed to it, SDG 3 through maternal, child, and newborn health, improvement in fertility, but almost all the SDGs that I've talked about, environment, social protection, reduction in inequalities, urban household living standards, education, and importantly, the whole relationship with the living condition and environment, water, sanitation, hygiene, all contributed to reduction of stunting in Peru. And it's not just Peru. If you go to other country exemplars that we have looked at, listed here, Kyrgyz Republic, Nepal, Senegal, Ethiopia, and you look on the right as to what were the relative contributor factors, most of these are the Sustainable Development Goals that I have been talking about. In terms of whether or not this holds true for subnational conditions, we have looked at this recently in Pakistan, comparing the north where there was change with the south. And once again, if you look at the drivers of what changed for stunting in these poorer regions of Pakistan, it's really investments in education, investments in reducing gender disparities, improving living conditions, and access to family planning. So what does all of this mean? How do we translate some of this research into policy implementation in the context of SDGs? So we looked at this recently by asking ourselves 3 questions, and this is the project funded by IDRC and AKFC, where we asked very simply, what has happened globally since these SDGs were launched in 2015 using a systematic review? what is actually happening in countries through these country case studies, and what could be done as we move forward. And the results were extremely interesting, and I will try and summarize this very quickly. So based on the 124 countries that we had some studies for, and a relatively limited set of studies, look at the greens, which are where progress has been perhaps to some extent satisfactory, and the reds outweigh the greens. So in most instances, there seem to be still 5 years into the SDGs, a lot of gaps in terms of stakeholder engagement, collaborations, focus on equity and reduction of disparities, and very importantly, in capacity development to monitor and implement the SDGs. We then went a step further and did some in-country and regional consultations across the globe based on countries that we had selected in terms of data availability. And the bottom line findings from those were that there was a lot of gap in between what countries wanted to do and where the planning process was, and that integration was recognized to be central to the development agenda. So what we have recommended, and I'll close with these 5 or 6 key messages, that to attain the SDGs in the remaining time, you need the political will. You need government leadership and multi-sectoral planning, and this requires champions in countries and also the role of academia and civic society collaborating together. You also need devolved implementation. You need to take this to where people are marginalized. So focusing on people who are actually in greatest need and focus on disparity reduction in countries. And therefore, central planning processes have to link with provincials, which is a gap that we found in most of the countries where we looked at. I've already spoken about reaching the unreached. So the focus on achieving equity and reaching the most marginalized. And as we grapple with COVID-19, this is considered to be one of the dominant drivers of excess mortality that we have seen in some subgroups, people who have just been dropped through the safety nets, who have fallen through the cracks and are not part of society in the same manner as others. There is a great role we feel for civic society in terms of advocacy, but all of this also requires financing. And while there is the need for development assistance, we also recognize that I had set out the outset that national governments should lead this agenda and will have to make provision for both human resources and implementation platforms to make this happen. And finally, we need the accountability. We need the data, the monitoring and evaluation, and the creation of think tanks at a national level. So let me close by just citing from Banerjee and Duflo, the Nobel laureates from last year in economics, that just talking about the problems of the world without talking about accessible solutions is actually paralysis by analysis rather than progress. And I hope that we can make progress jointly as we move forward in achieving the Sustainable Development Goals. Thank you very much for your attention. And sorry about the glitches.
Thanks so much, Dr. Bhutta. As always, it's a pleasure to listen to you as you presented now on one of the exciting projects that also IDRC is proud to have contributed funds to. Your work has showed us, among other things, I mean, there are so many rich points you have in your presentation, but it showed us, among other things, that strengthening the capacity at the subnational levels is essential to translate political commitment into strategies to benefit common people to achieve the SDGs. And so important for today's pandemic context that the paradigm shift to integration and prevention is needed to achieve health and health-related SDGs, which hasn't yet been meaningfully materialized. And so thank you so much for this. Now it is my pleasure to honor to introduce the keynote lectures by Quarraisha and Salim, Drs. Quarraisha and Salim Abdul Karim, the 2020 John Dirks Canada Gairdner Global Health Award laureates. Quarraisha Abdul Karim is Associate Scientific Director, CAPRISA, Professor Clinical Epidemiology, Columbia University, New York, Professor Public Health, Nelson Mandela Medical School, and Vice Chancellor, African Health, University of KwaZulu-Natal, Durban, South Africa. And Dr. Salim Abdul Karim is a Director, CAPRISA Professor in Global Health, Columbia University, New York, Vice Chancellor, Research, University of KwaZulu-Natal, Durban, South Africa. They will speak to us about lessons from HIV for the COVID-19 response. Thank you so much for being here with us today.
Thank you very much, Dr. Kamal. It's a great pleasure and an honor for both Quarraisha and I to be here this evening. I'd like to acknowledge the Gairdner Foundation for recognizing our research, and in particular, because our research recognizes the importance of women and the empowerment of women as part and parcel of dealing with the HIV epidemic. So what we wanted to do today was to talk about what are some of the lessons we learned from HIV that would be relevant to the COVID-19 response. I'm just going to try and move our slides. Next slide, please. Yeah, so when we look at the global burden of COVID-19 and HIV, it's quite striking that by this stage, both diseases have about 39 million people who have been cases. And when we look at the deaths, we see that COVID-19 has now exceeded the number of deaths from HIV last year. Next slide. And when we look at the lessons, we wanted to share 10 things that we found were useful as we have tackled the COVID-19 epidemic, and what were things we learned from HIV that were helpful. Next slide. So the first thing that we found very helpful was the underlying premise that in order to deal with HIV, you really needed to know your epidemic. HIV epidemics are so different country by country and within a country, region by region. And so knowing your epidemic, using data to understand the nature of the epidemic, identify your hotspots. And UNAIDS and WHO provide a whole range of guidance about how to know your epidemic. What are the elements that enable you to know your epidemic? Because if you don't know your epidemic, your response is not appropriate to that epidemic. Next slide. And if we look at how we have tackled this problem in South Africa, in terms of SARS-CoV-2 epidemic, we've taken those lessons. We have looked at identifying the hotspots for COVID-19. We've looked at understanding our data at a local level, at a regional level, to understand when it is going up, when to increase restrictions, when to do it. So the whole idea of knowing your epidemic, knowing your response, has been the way in which we have tackled it. Next slide. But that is all part and parcel of appreciating the centrality of scientific evidence in the response. We do that with HIV. And certainly in South Africa, very early on, we published the scientific approach of defining the 8 stages of our response, exactly what we are planning to do when and how we are doing that in relation to the data. Next, please. And all of that, of course, is predicated on the basis that we have to deal with the complexities of politics. In South Africa, we've had to deal with HIV denialism when our previous president took that approach. And of course, we saw similar things going on in the US, where the president also was illustrating this playing down the effects of making it seem like this is not a problem. Next slide. But in all of this, the thing that struck us most is how, when we were dealing initially with HIV, you couldn't deal with HIV without dealing with the conspiracy theories, and they abounded. When something is not known, something is scary, the way people deal with fear is they find some rationality to make something fit what they're seeing, and the conspiracy theories abounded. In COVID-19, similarly, coronavirus conspiracy theories abounded. This study from Cornell University, where they looked at 38 million articles, 1.1 million had misinformation, most of them on conspiracy theories promoted by the president. Next slide. So the importance of data, the centrality of science, and the way in which politicians do their decision-making or go through the decision-making process with evidence. But also, they need to be consistent role models. They cannot be promoting and saying one thing and doing something different. And we've been very fortunate that we've had leaders in our country that have done that, who've been excellent role models that all of us can follow. Next slide. But in the midst of all of that, next, we also see how we have had the opposite as well. How in our neighboring country, Swaziland, the king had imposed a chastity vow, but then he went and broke that chastity vow himself when one of his maidens became pregnant. Similarly, we saw in the UK how Dominic Cummings broke his own rules on the lockdown. Next. So in looking at knowing your epidemic, looking at the centrality of scientific evidence, and ensuring that leadership play a consistent role as role models, let me hand over now to Quarraisha, who's going to talk about the next 6 lessons.
Thank you very much, Salim. May I have the next slide, please? Greetings, everyone. So you've heard about the political context that's needed and consistency, but also about the importance of scientific evidence. And in the absence of a vaccine, how do we respond to the epidemic? How do we respond when there's uncertainty in terms of what we know and what we don't know? And both with HIV and with COVID, we start with what makes sense. And as our knowledge grows and as evidence grows, that expands. And when we have options to choose from, our ability to respond effectively increases. But at the same time, we have to recognize that what we're dealing with is a diversity of epidemics between and within countries, and also what's driving these responses change. So when you have this expanded menu, may I have the next slide? Please? When you have an expanded menu, it's not about making everything available to everyone, but very carefully choosing combinations that are appropriate for the situation. And I want to just dwell for a second on the COVID response. For example, we know that the non-pharmaceutical interventions of hand washing, of social distancing, and mask wearing is critically important for containment of the epidemic. And an extreme form of social distancing is lockdowns. And that should be used very parsimoniously. And so it just reinforces it can't be one size fits all, but that how do we work in a way that makes us more responsive with the evidence as it becomes available. May I have the next slide, please? Now, an important starting point is knowing who is infected. And when we first started responding to the HIV epidemic, we had the Western blots that needed to be confirmed, and it would take weeks and weeks before you could get a result. And it wasn't until we'd progressed from ELISAs to antibody tests that we were able to rapid tests, where we were able to rapidly respond to the epidemic. In the COVID response, similarly, we've started with PCR technologies that take a day or a few days to get the results, but we're also seeing this rapid evolution of point-of-care testings that will enhance our ability to identify cases and enhance our response in containment. May I have the next slide, please? Now, having these tools are an important first step, as is knowledge of what is available. But it is only the first step and a necessary piece in the equation. Where the gap and challenge lies is how do we have behaviors change to adopt these? And quite often, things like pamphlets and posters disseminate information, but they're not sufficient for enabling the behavior changes, because enabling behavior change actually needs a lot more. But on messaging for change and to be supportive, what we have learned is scare tactics don't work. In the early days, we saw the use of the Grim Reaper that had little impact. But then as we create enabling and supporting environments for behavior change, we see those being adopted. And may I have the next slide, please? And you can see this with COVID-19. Unless you provide the sanitizers, unless you give clear instructions on mask wearing and create access to those options, you'll have limited uptake or impact on behaviors. May I have the next slide, please? What we've also learned is that quite often the lead is taken rightly by governments in responding to epidemics, but that governments are more effective in their response when they work with people. And sometimes we can use the phrase, do things with people, not on people, or also nothing for us without us. In the very early days of the AIDS epidemic, we saw how important activism and social movements were to enhance our response. And as our knowledge grew and our experience that expanded, and we've seen how important that is both for advancing the science, but also for accountability, for human rights lens, and dealing with the fear, with the anxiety, and with stigma, because this is where the leadership is. This is who knows the communities in detail. May I have the next slide, please? And it is one important lesson that, for example, in the South African government, where initially a task force was set up for dealing with providing scientific evidence, was followed very shortly thereafter with the establishment of a ministerial advisory committee for social behavioral change that included leaders from faith-based organizations, civil society, and also from labor unions. May I have the next slide, please? Now, one of the issues that still remains a big challenge, Zulfi mentioned it in his presentation, but in HIV as well, is the gender inequities. And we'll be talking a lot more. If I had all day, I would spend a lot more time talking on this. But I just want to highlight how important it is in Africa that we recognize that a lot of the driving force behind new infections that continues despite the high burden of infection is the age-sex difference, whereby young women acquire infection 5 to 7 years before men, and by age 15 to 24 years have about 7 to 8 times more infection compared to their male counterparts. May I have the next slide, please? In our research efforts, we've tried to fill that gap in terms of creating women-initiated technologies, but to a large extent, the research agenda in terms of developing technologies miss the gender aspect of what are the needs of women. Now, in the coronavirus, we're seeing the same thing. Our first responders are primarily women. We have largely women-headed households in Africa, many self-employed women, many women working in the informal sector. But even in the formal environment, what we've seen with stayaways, with lockdowns, is that burden triples on women, if not quadruples. What do I mean by that? Women are first responders, providing in the manufacturing sector, in the health sector. But when it comes to, they have to go home and do the household responsibilities, looking after children, educating children with schools that are closed. And yet the demands on them are highest. And when it comes to job losses, you see this first in women, you see women losing jobs, but also extreme forms and manifestations of the impact on women comes from the increase in gender-based violence that we've seen, and particularly hard hit are young women 15 to 24 years of age. May I have the next slide, please? Now I'm going to move on to my last point, which is around universal health care. And here what we know and what we knew from 1996 to about 2003 was that where you were, if you had AIDS, defined whether you would live or whether you would die. And it wasn't until 2000 when we had this global call to action at the 13th International AIDS Conference, shortly thereafter the establishment of the Global Fund for AIDS, TB, Malaria, and the US Presidential Emergency Program for AIDS Relief, that the bridge between who could access life-saving antiretroviral treatment started to be bridged. And today we can proudly say over 25 million people have been initiated on antiretroviral treatment through this global solidarity, including drug access and drug price reductions. But we still have 10 more million people and counting who still need to be initiated on treatment. And if we look at the next slide, please, the COVID situation, what we continue to see is these disparities and fault lines in society manifesting in terms of who is bearing the burden of infection. Again, it's those who are racially marginalized on the basis of ethnicity, gender, age, etc. And these disparities continue. So sometimes we learn lessons, sometimes we don't learn lessons, but it's worth reminding ourselves. And with that, I hand you back to Slim.
Can I get the next slide? So I hope we've given you some impression of the first 9 lessons that we took away from HIV in how we assisted and advised and tried to define the response to the COVID epidemic in South Africa. Knowing your epidemic, understanding the centrality of scientific evidence, ensuring that leaders were consistent role models, and then trying to develop as wide a prevention toolbox as possible so that there are lots of options. Ensuring that, and we saw the value of a rapid test. Rapid testing in HIV changed how we approach the disease. And I have no doubt it will do that similarly for COVID-19. But then we had to grapple the long-term challenge of behavior change. And we knew the importance of community engagement in this process, and that we couldn't engage with the communities without addressing some of the fundamental inequities that go with that. I'm now going to touch on the next slide, please. I want to now touch on the last point, which is one of mutual interdependence. Because of the nature of the COVID-19 epidemic, we knew that very early on that we just did not have the time in order to follow our traditional public health response, where we would collate all the evidence, we would develop a strategy, we would pilot test it in a community, we would adapt it, and then we would look for early adopters. But we knew that that was not a viable way to deal with this epidemic. If we waited for that, the epidemic would have gone beyond that. So we had to institute early action. And that action took the form of government-imposed restrictions. And so that government-imposed restrictions using institutional authority created anxiety. People were unsure about what was going on. Why is the government taking this kind of action? But we knew that that was not a sustainable approach. It couldn't be done for more than a few weeks. And so we had to pivot. We had to pivot the response from anxiety to giving individuals agency so that they could achieve self-efficacy. And the way we had to undertake that pivot was to move that power away from government and to put it back in the hands of individuals so that they could see that I can control my own risk of infection. I can control it through my actions, whether I wear a mask, whether I don't wear a mask. But that we had to move even further and pivot next from individual action to one of collective action. We had to try and reach a stage where we looked at it as a collectivism. And that fits in well with the South African philosophy of Ubuntu, which is promoted by President Mandela. One of, I am because you are. I am safe because you are safe. You are safe because I am safe. Our mutual interdependence is our weapon to protect ourselves against this epidemic. Next slide. And we knew this because it was the basis on which we acted against HIV. And in this statement from UNAIDS, that the AIDS movement demonstrated that a shared vision, a shared responsibility, and global solidarity and leadership is what led us to our approach. And so you saw the creation of global solidarity through the Global Fund, where rich countries provided funds in order to ensure that poor countries, people wouldn't die from HIV because they couldn't access treatment. Now we are seeing that in COVID-19 through the COVAX, where we don't want to have a situation where the rich countries have access to a vaccine and the rest of us will wait in turn for 5 years later when there's vaccine available for us. That's got to change. And so this mutual interdependence, the belief that we can vaccinate one country while the rest of the world has the virus spreading, is a solution to this epidemic is no longer. Last slide, please. And so as we look at our mutual interdependence, I want to make some concluding remarks. That in HIV and COVID-19, science has changed in so many ways. I mean, just in COVID-19, over 70,000 articles in 10 months, more than 300 a day. And there's a range of quality issues, but look at the explosion in science. In both pandemics, scientific evidence assumed new importance in decision-making, providing guidance and challenging conspiracy theories. And in AIDS, we dealt with the politics of Becky and denialism, but ultimately, scientific evidence through antiretrovirals won the day. In COVID-19, similarly, we'll go beyond all of these political machinations because science is going to come and save the day. And I want to end off by saying that HIV and COVID-19 have provided us with a new lens for the nexus between science, policy making, and global health as we pursue sustainable development goals with equity and social justice as our guiding principles. Thank you.
Say I cannot join.
Thank you very much for that enlightening speech and for bringing. Oh. Hello? I hope you can still hear me. Thank you for bringing that humanity to the science at the moment in terms of how you have responded to both HIV and the COVID epidemics in South Africa. And really thank you again for your contributions, both Quarraisha and Salim. I am now have the pleasure of inviting our next speaker, who is likely the most famous scientist in North America at the moment, although given the security detail that he has to be traveling with, I'm not sure it's the kind of attention one is wishing. I would love to pepper Dr. Fauci with a million questions about how to communicate the messiness of emerging scientific knowledge in a way that instills public trust in science. But instead, we'll give him a bit of a break from that and ask him to provide his perspective on emerging and re-emerging infectious diseases. Dr. Fauci, the floor is yours.
Thank you very much, Gully. It's a great pleasure to be here, and particularly following and joining my good friends, Slim and Quarraisha. I'm going to talk a bit about the concept of emerging infectious disease, but I'm going to focus very heavily on COVID and show you maybe the evolution of how we've gone from so many threats and realities to a really profound reality of an emerging infectious disease. Some of my friends know that I've actually been director of the National Institute of Allergy and Infectious Diseases. Now it'll be 36 years in a couple of weeks, as you could see from this November the 2nd, 1984. The reason I show this, besides to remind my friends that I did look young at one time, is that the first time I testified before the Congress, I drew this map as an example of what we might be facing. The first emerging infection I put on the map was HIV, which soon became a global pandemic. But over the years, I continually testified before our Congress, and I showed the same map, but I add one, sometimes two, sometimes three new infections each year, some of which are curiosities with no global impact, but others which are profound in their impact. This is a picture of the last one I showed literally just a couple of months ago. And you could see the extraordinary number of both newly emerging and re-emerging and resurging infectious diseases. But for the purposes of today, I want to talk to you about something that I said now about 4 years ago when I was interviewed on C-SPAN and someone asked me what I was really concerned about. And I said my number one concern was the idea of emerging infections that we haven't been exposed to before that's spread by a respiratory route and that has certain characteristics of efficiency of spread and high degree of morbidity and mortality. And here we are. This is a paper that I wrote just a few months ago in JAMA. It was a viewpoint right at the time that we were seeing the early emergence of COVID out of the Wuhan district of China. And I wrote this with this title, Coronavirus Infections More Than Just the Common Cold, not at all to be facetious, but what I wanted to point out to the readers was the fact that we have been dealing with coronaviruses for decades and decades. And this is a phylogenetic tree of the coronaviruses with the human viruses in red letters. But as you can see, there are also viruses that are in bats and other intermediate hosts, some of which are phylogenetically very similar to the human viruses. This is what the situation was for decades and decades, until 2002, when we were confronted with the SARS pandemic, which began in the Guangdong province of China, from a bat to a civet cat to a human, leading to a pandemic that I'll describe in a moment. And then in 2012 came the Middle East respiratory syndrome, another pandemic coronavirus. So we went from the common cold coronaviruses shown in yellow on this slide, which account for about 15 to 30% of all the common colds that we repetitively experience, usually during the winter months, to the first confrontation of two pandemic coronaviruses. Now, you might remember SARS, which began in 2002 at 8,000 people, almost 800 deaths. It was controlled purely by public health measures, likely because the efficiency of its spread from human to human was not nearly as good as what I'm going to talk about in a moment. In 2012 came MERS, so the Middle East respiratory syndrome, again, likely from a bat to a camel to a human. Still now, there are new introductions of this virus into the Middle East. So this potential pandemic is still smoldering. Fast forward to today, January of 2020, we first had the awareness of a clinical syndrome that was recognized in December of 2019, finally recognized by the Chinese as a novel strain of coronavirus and put on a public database. And as you see here, its proximity to the original SARS coronavirus 1, which led to a change in nomenclature. So what we have now is that the disease caused by SARS coronavirus 2 is called COVID-19, a coronavirus disease 2019. And as I mentioned a moment ago, the terminology for the viruses was switched. The original SARS became CoV-1, and the one we're dealing with now becomes CoV-2. So where are we with this extraordinary disease? It has exploded upon us in pandemic fashion, the likes of which we have not seen in the last 102 years since 1918, which the current numbers from just a few days ago have about 40 million cases and over 1.1 million deaths. The United States of America has been the most severely hit country, with now over 8 million cases, and now the last count of yesterday, 220 million deaths. This heat map of the United States shows the number of cases per 100,000 population, and note the concentration in the southern states of the United States. Now, I want to point out something that I think would be of interest to the audience. When you compare the dynamics of the outbreak in the United States versus the European Union, several informative issues arise. If one looks at the blue line, which was in the European Union, dominated by northern Italy, exploded with cases that peaked in March and mid to early March. When that was brought under control, the cases came down to a very low baseline, as shown in the blue line in April through the beginning of August, the end of July. In the United States, it became much more complicated. when we had an explosion of cases, it was dominated by the New York metropolitan area, which at one point accounted for about 40% of all the cases, hospitalizations, and deaths. But we never went back down to a very low baseline because as New York recovered, other areas of the country, so that our baseline of daily cases was about 20,000 per day until we decided to so-called open up the country, open up the economy, which was done in a disparate way, differently by different states, to the points that we had a surging of cases up to 70,000 a day, which came down. And where we are right now is the beginning of another surge, where if you look at the numbers from yesterday, we have now between 55 and 70,000 cases a day in the United States. But also look at the blue line. Now in European Union is beginning to have the resurgence in multiple countries. But just to ask the question, why did we in the United States not go down to the baseline when you compare the red to the blue line in April, May, and June? It was because we did not close down as completely as one would have thought. If you look at using GPS, at the time moving in parks and outdoor spaces, the United States did much less than Italy and Spain, which use as a representation of the European Union. When you talk about workplaces, again, see how the United States did not diminish as much as Italy and Spain. And this is particularly evident when you look about visits to groceries and pharmacies, where again, the United States did not close down nearly as much as Italy and Spain. So that's a snapshot of the epidemiology. Let's take a look quickly at the virology, which we're very familiar with now. This is a beta coronavirus, an RNA virus with multiple structural proteins, the most studied of which is now the spike protein, which is receptor binding domain, which binds to the well-recognized receptor, the ACE2 receptor, on multiple tissues throughout the body, upper and lower airway, GI tract, cardiovascular tissue. The transmission modality is clear. It's a respiratory-borne virus spread by larger droplets, which within 6 feet tend to go to the ground, but also recent indications show that there is an aerosol component of droplets that stay in the air now for longer periods of time and space. There's less commonly contact with contaminated surfaces as an important modality, and the virus is found in multiple body fluids, but their role in transmission is unknown and likely not important. Now, the risk of transmission varies by the type and duration of exposure and factors such as viral load. Transmissions are seen among household contacts, healthcare settings when PPE is not properly used, and particularly in closed settings, such as cruise ships, nursing homes, and prisons. The factors that may increase the risk of airborne transmission are crowded spaces with poor ventilation, and even things like speaking loudly, breathing heavily, or singing. We have recently found that that is likely the case, arguing again for the importance of masks. Here are some examples of congregate settings in a choir in the state of Washington, in which one symptomatic individual in the closed space of the choir in the church infected 87% of the people in the choir. Here are some examples of other congregate settings: family gatherings in Chicago, church events, social events in Arkansas. Again, congregate settings are clearly an important risk factor. Another important issue that we have found recently confirmed is the high percentage, from 40 to 45% of infected individuals are asymptomatic. And importantly, modeling studies show that a substantial proportion of infections are from a person who has no symptoms to an uninfected person, which leads to the fundamental tenets that we use of encouraging people to avoid the acquisition and transmission of SARS coronavirus 2 is the universal wearing of masks or cloth face coverings, maintaining physical distance where possible, avoiding crowds and congregate settings, particularly indoors, and trying as best as possible to do things outdoors as opposed to indoors, and frequent washing of hands. The clinical manifestations, very interesting, very much like a flu-like syndrome early on. In addition, a curious loss of smell and taste that precedes the onset of respiratory symptoms. In addition to the 40 to 45% that have no symptoms, those who do have symptoms, about 80% are mild to moderate, requiring little, if any, medical intervention. However, about 15 to 20% are severe and critical. And of those, the case fatality rate varies from a few percent to up to 25% in people requiring mechanical ventilation. The manifestations of severe COVID-19 are predominantly the acute respiratory distress syndrome, but recent clinical experience indicates a disturbing amount of things like cardiac dysfunction with cardiomyopathies and arrhythmias, and sometimes sudden death through cardiac arrest, kidney injury, neurological injury, a very curious hypercoagulable state leading to microthrombi in small vessels, as well as thromboembolic phenomenon leading to stroke, as well as a curious multi-system inflammatory syndrome in children reminiscent of Kawasaki syndrome. Some people, and now we're studying this intensively here in the United States, suffer from what's called a post-COVID syndrome, which anywhere from weeks to months or longer, one have lingering symptoms such as shortness of breath, muscle aches, extreme fatigue, dysautonomia, and a syndrome which they refer to as brain fog, or an inability to concentrate or to focus mentally. The people who are at increased risk for severe COVID disease are older individuals. This is a striking slide looking at the rate of hospitalization per 100,000 population in the young on the left-hand side, all the way up to the elderly shown on the right-hand part of the slide. In addition, people of any age with certain underlying medical conditions are at high risk for serious consequences. They're shown here on this slide. People who have these types of diseases, obesity being very important, diabetes, chronic obstructive pulmonary disease, clearly have an increased risk for severe disease. Other conditions, there may be a risk. They're shown on this slide. I'll point out a few: hypertension, diabetes, the immunocompromised state, for example, by individuals who are immunosuppressed for a variety of diseases. In the United States, this is interesting. A substantial proportion, up to 30 to 40% of people actually have these underlying conditions, which if they get infected, would make them susceptible to severe disease. Another issue we're facing in this country is the extraordinary and very troublesome disparities racially and ethically, both in the rate of infection as well as serious consequences because of the prevalence of the underlying comorbidities that we see more in our African American and Latinx and Native American population. This is a striking slide. Again, if you look at the rate of hospitalization per 100,000 population, look at the difference between Hispanic, Latinx, Native Americans, and Blacks at 370 through 387 per 100,000 compared to whites at 86. Moving on to therapeutics, we here have developed at NIH a treatment guidelines panel made up of experienced clinicians from throughout the country and the world who meet regularly and have actually created a living online document that updates clinicians on the management and treatment of COVID-19 disease according to the latest clinical information. The therapeutics for COVID-19 are shown here on this slide. There are a couple like remdesivir and dexamethasone that have actually been shown in randomized placebo-controlled trial to have a significant diminution in the time to recovery in hospitalized patients requiring oxygen. A study from the UK showing dexamethasone reduced the 28-day mortality in hospitalized patients requiring ventilation and requiring and needing oxygen. But there are also therapies that are now being tested in multiple clinical trials for early on in infection, Some of them are shown on the bottom of the slide here. Antivirals, convalescent plasma, hyperimmune globulin, quite cautiously optimistic now about the potential role of monoclonal antibodies against SARS-CoV-2. Now, let's finally finish here with vaccines. Clearly, always the hallmark of control of pandemic outbreaks. We've adapted in the United States what we refer to as a strategic approach to COVID-19 vaccine research and development, which we articulated with my colleagues in a relatively recent commentary in Science. By a strategic approach, I mean the following. There are 11 vaccine candidates globally that are in advanced phase 3 trial. We in the United States are supporting either by the development of or facilitation of the testing of 6 of these. I'll mention them in a moment. But when I say a strategic approach, I meant the harmonization of protocols so that you can have a common data and safety monitoring board, common primary and secondary endpoints, and common immunological parameters to measure as correlates of immunity. These are the 3 platforms on the left of the slide that are now being tested. Nucleic acid, namely mRNA, particularly the Moderna and Pfizer companies, viral vectors, such as chimp adeno, human ad26, as well as VSV, and then finally, the standard and more classical protein subunits with an adjuvant. Note on the right-hand part of the slide, there are now 5 of the 6 that I mentioned that are in phase 3 trial. 2 of them began on July 27th. And given the rate of infection that I showed you in this country, and given the sites, which are many, that the clinical trials will likely give an answer to the safety and the efficacy of vaccines, likely more than one, by the end of this calendar year. And we would project by late November, early December. One can never predict, who's been involved in vaccinology, the success of this. But we feel cautiously optimistic that one or more of these candidates will be safe and effective based on very encouraging animal data, as well as phase 1 trials that show the induction of neutralizing antibodies that are comparable to, if not better than what we see in natural recovered infection with convalescent sera. And again, what will be done is that vaccine doses are already being made to be able to not only cover people in the United States, but partnering with companies that have promised to make billions of doses so that, as Slim had mentioned a little bit ago, there will be availability throughout the world, not having to wait for a substantial period of time for vaccines when it becomes available. One of the problems we have here in the United States is that there's a reluctance on the part of many to get vaccinated because of somewhat of an anti-vax approach. Disturbingly on this slide, note the yellow and orange, which is either they don't want a vaccine or they're not sure they want it. And take a look at the most vulnerable in our population, which are the minorities, African Americans and Hispanics. You can see that if you look at the yellow plus the orange on the 2 lower levels of the slide, a disturbing number of people are not that sure that they want to get vaccinated, some of which don't want to. We need to reach out to the population at the community level to make sure that the most vulnerable are protected. Now, I'm going to stop with this last slide, which my colleague and I wrote last month in Cell, Emerging Pandemic Diseases. How did we get to COVID-19? And as Dr. Morins and I, we discussed in some detail in this paper that disease emergence reflects dynamic balances and imbalances within complex, globally distributed ecosystems comprising humans, animals, pathogens, and the environment. And looking forward, as we prepare for next outbreak, understanding these variables is a necessary step in controlling future devastating disease emergencies. Again, thank you very much for giving me the opportunity to make this presentation.
Thank you so much, Dr. Fauci. It's a pleasure to have had you here with us. I know there's many things one can comment and indicate what we've learned from your presentation, but I know we are short on time. So thank you so much for showing us that there's still so many bridges that need to be built between science, policy, and communities to promote public health. And now it's my honor to introduce the next two presentations and discussion panel. Doctors Lawrence Haddad and Yasmin Chandani will both be presenting individually on their work, and then will be joining Doctors Adelstein Brown, Dean Professor in Dalla Lana School of Public Health, University of Toronto, for a discussion alongside Doctors Quarraisha, Abdool Karim, and Zulfiqar Bhutta. Dr. Lawrence Haddad is the Executive Director for the Global Alliance for Improved Nutrition and 2018 World Food Prize Laureate. He will be speaking about COVID-19 and global malnutrition, a sting in the tail or a chance to remake our food systems. Dr. Yasmin Chandani is the CEO of In Supply Health Limited, and she'll be speaking about building resilient health supply chains to achieve the SDGs 2020 and beyond. The floor is yours.
Thank you so much, Chair. It's a pleasure to be here. I'm going to talk to you today about COVID-19 and malnutrition. And, you know, Dr. Fauci reminded us that so far, COVID-19 has taken about 1.13 million lives. And it's important to remember that every year, 2.5 million kids under the age of 5 die from malnutrition-related causes globally. So the challenge is, how do we make sure COVID-19 and the associated lockdowns don't exacerbate that number greatly? And what can we do to change the nutrition and food systems in the future to make sure that the systems are stronger now, but also stronger once, hopefully, a vaccine becomes available? I'm trying to click, but it's not letting me do it. Okay. So there are three big routes through which COVID-19 affects malnutrition. First, an economic route. Second, a food system route. And third, a health system route. Economically, the lockdowns and the restricted movements mean that there are lots of job losses and there are income losses. The food system is disrupted, decimated actually, by the failure to move food around and to get inputs to farmers and food to market. And the health system, a lot of essential nutrition services are delivered through health systems. So these three sets of disruptions mean there's less nutritious food available. The food that is available is expensive. And a lot of the nutrition programs that are so essential for young children and maternal, and for women who are pregnant and lactating, those programs are not available. And also hygiene services are severely disrupted. That means diet quality diminishes, morbidity increases, those two interact with each other, and we get a whole generation and a whole host of malnutrition outcomes, which have huge costs in terms of mortality, morbidity, distress and pain, and economic consequences. Next, please. In terms of the economic consequences, these are the latest figures from the IMF from October, just earlier this month. And you can see the pink bars are the declines in GDP projections for 2020. India, a 10.3% decline. That's absolutely massive. Latin America, bigger declines. Sub-Saharan Africa, less large declines. But Nigeria and South Africa, two of the biggest countries in Sub-Saharan Africa, big declines. What's worrying, especially for the African countries, is that the bounce backs, which are the green bars, are much smaller than the declines. Next, please. In terms of access to nutritious food, so let's go to the food system now. Nutritious foods tend to be the most perishable, and then therefore they tend to be the most vulnerable to food system disruptions. You have piles of nutritious food rotting over here, and a scarcity and a dearth of nutritious food 50 kilometers away in an urban market. We don't have a lot of data to show this in terms of survey data. Here's a piece of data, a survey that was done in Ethiopia, in Addis, in May, and it shows clearly that dairy consumption has been severely hit by the lockdowns and by the income drops in Addis. And this is really important because dairy is an important source of essential nutrients for especially young children and pregnant and lactating mothers. Next, please. The health system disruptions are also very serious. This is some data from UNICEF from the summer. And again, it shows for a different number of countries. The horizontal axis is number of countries. It shows for these 7 different nutrition interventions what's happening to the disruption of services. Red means really bad disruptions. Gray means hardly any disruptions. And you can see for some of the programs, like the school feeding programs, which is the bar with the big red section, school feeding programs are just not happening. And that's because schools are closing down, kids not going to school. But in many of the other interventions that are essential for nutrition, they are also being severely disrupted. Next, please. What is this? What's this generating? This income drop, this nutrition service drop, this increase in the price of nutritious foods? What's happening? Well, so far, the only estimate we've got is the impact on wasting of under 5 children. Wasting is when children are too thin for their height, they become skin and bone. And you can see the latest estimate. It's a set of estimates that we generated and came out in the Lancet in July 2020. You can see that the number of wasted children goes from 47 million to 54 million. That's an increase in 7 million. To put that in context, it took about 10 years to get a decline from 54 million to 47 million. So in 10 months, we've reversed a decline that took 10 years. Next, please. And this is just the tip of the iceberg. Wasting is a leading indicator. It's the thing that goes first. Weight goes first. Height and other manifestations take longer to show themselves. And there's a lot more to come in terms of stunting, micronutrient deficiencies, and so on, and mortality. So we really have to act now. Next, please. So this is a chance to mitigate these negative consequences, but it's also an opportunity to build not back better, because building back better implies that we were happy with where we were, but it's actually a chance to build forward better. So here are some things to do on the health and social protection sides. So on the income side of things, what can we do to design programs that are good at mitigating this income drop? Well, social protection programs, these are programs that deliver cash and food to very vulnerable households. We did an analysis of the 200 programs that the World Bank has in their database that responded to COVID-19, and none of them linked to the promotion of the production of nutritious foods or the consumption of nutritious foods. And they could so easily do that. Next slide, next, please. And in terms for child development, especially of children under the age of 3 or under 5, I talked to you about how those economies can bounce back, but children under the age of 3 cannot bounce back if those disruptions to their nutrition in the first 2 or 3 years of life are not remedied within that window. If it's not remedied within that window, those losses are irreversible, and they will carry those consequences throughout their life. So we have to ensure antenatal care, breastfeeding promotion, vitamin A supplementation, and food fortification. These essential programs are part of the COVID-19 response. They're not separate from COVID-19 response. They are built in to COVID-19 responses. Next, please. Dr. Fauci talked about how important non-communicable, diet-related non-communicable diseases are. And here we have a chance to say, look, if you want to minimize the symptomatic effects of COVID-19, take diabetes type 2, take obesity, take hypertension seriously. And this, in the UK where I live, this was a trigger for the Prime Minister just recently to initiate a whole range of actions to combat childhood obesity. Next, please. On the food system side, I think one of the big reveals of COVID-19 has been how essential food system workers are. Workers in the health system are frontline and essential, but I think many of us have realized how important food system workers are. And this has been a spur to lots of businesses and other employers to put in place workforce nutrition programs. If our workforce in the food system gets sick, that's terrible for them and their families, but it's also terrible for the rest of us. And so workforce nutrition programs are a proven 4-to-1 benefit cost ratio intervention to combat that. Next, please. One of the other big reveals has been how important small and medium enterprises are, especially in sub-Saharan Africa and South Asia and Southeast Asia. They are the backbone of local food systems. They are what most low-income people depend on, small and medium businesses, but they don't have working capital to help them get through the shocks from lockdowns and other economic depressions. They need financing facilities. At the moment, they don't get that. They're too big for microfinancing and they're too small for commercial finance. We need new mechanisms, new impact investing mechanisms that target exactly that size of company. Next, please. And finally, we've been really surprised at GAIN in the 9 countries that we have country offices in Africa and Asia, how rapidly fresh food markets have been closing down because of lack of protocols to prevent infection and lack of PPE, again, to prevent infection. So we've been working with the World Health Organization and other organizations to develop those protocols and that PPE to keep these food markets open, because these are the fresh food markets where highly nutritious foods are sold. If those markets have to close down, the price of those foods skyrockets and food waste skyrockets. Next, please. So my last slide, Chair. Unchecked COVID-19 and the lockdowns associated with it will really threaten to reverse 10 years of progress in the fight against malnutrition in 10 months. Next, please. We need to deny COVID-19 this intergenerational legacy. As I said, economies can bounce back. Yes, there's temporary pain, but they can bounce back. But children, especially under the age of 2, cannot bounce back if we do not reverse those declines in malnutrition in the first 2 years of life. They will carry that on with them throughout their lives, and that'll be a legacy of the current crisis. Next, please. We need to build forward better, not just building back better, but building forward better. The policy space is really fluid. Things that are unimaginable have become imaginable. Things that seemed undoable have become doable. And we need to make the case for nutrition as a routine part of the COVID-19 response in the economic, food, and health sectors. Next, please. And finally, is it a sting in the tail or a chance to remake our systems? Well, there's lots we can do to minimize that sting in the tail, and lots we can do to remake our food and nutrition systems. And actually, if we do it right, we can address both of those things. Thank you very much.
So good afternoon, good evening, everyone. My name is Yasmin Chandani. I'm the CEO of In Supply Health, and I'll be sharing some perspectives today about building resilient health supply chains to achieve SDGs, looking at today in the context of COVID and beyond. Let's see if I can control my slides. I think I might need some help with my slides. There we go. Oops. Back one slide. A little bit about In Supply Health first, because it's relevant to sort of the way we work and my discussion today. We're an East African health advisory firm based in Nairobi with an office in Tanzania. We operate a little bit more like a social enterprise rather than a consulting firm. We have a social mission, but we believe very much in working across public and private sector to achieve impact and sustainability. We're affiliated with John Snow Inc., a US public health organization that's been working in global health for over 40 years. And a lot of our supply chain DNA comes from JSI. And as a team, we're very much driven by innovation, sustainability, and local adaptation. Next slide, please. So when looking at SDGs, we look through the lens, we support 2 through the work we do. And we look through the lens of supply chains and innovation. As my colleague, Dr. Haddad, just talked about, supply chains are a backbone for reaching, whether it's for health commodities, for food, for so many things. And we've all heard about the disruption of supply chains when it comes to COVID. So we believe that ensuring healthy lives and promoting well-being at all ages requires supply chains that reach clients with the products they want and they need. Also, we focus on reduced inequality, and reduced inequality means that these supply chains need to provide access for all clients, not just those that are easy to reach. So reaching those that are marginalized by the health systems and are not part of mainstream health systems requires radically different approaches, and that's where the innovation comes in. Next slide, please. So COVID didn't really show us any surprises. It revealed already known vulnerabilities in supply chains. We all know from toilet paper stories and other things how global supply chains were disrupted. And when you talk about health, what that means is a lot of the products reaching the ports. But it also disrupted local supply chains. And so these things, what I'm about to talk about, are things we already knew about supply chains and what was needed. We know that resilience is vital, that supply chains need diversified sourcing strategies, and to be able to update inventory policies, for example, in our current context, where the supply chain is not working the same. We saw inequities in access that were already there. They were further magnified, with remote communities having even less access than previously. We know that responsiveness is heavily dependent on data, yet many of our national health information systems are fragile, and in this context didn't have the data that was needed to try and respond effectively. We heard about the importance of client-centered approaches. In many countries, we've seen a dip in clients accessing essential health services. No one really, at least in our countries, no one wants to line up at busy health clinics and risk infection. So we know we need client-centered approaches that bring services and supplies to where the clients are and where they want to access them. On the positive side, we have seen something we've been striving for a long time. We've seen that remote and virtual approaches are feasible and they can be used to enhance self-sufficiency. Next slide, please. So what COVID did was it reminded us of the urgency of ensuring that supply chains are resilient, they're responsive, and they're equitable. And there's two primary ways in which we suggest we are trying to approach the resilience and responsiveness. The first is focusing on client-centeredness. We co-create solutions with our clients to ensure that their voices are part of the design, the implementation, and the adaptation. And this gives them a sense of ownership over the solutions and the outcomes and helps build that resilience and the responsiveness. The other really important part is enhancing data, from data visibility, from information flows. This is what makes products flow up and down the supply chain, but also fostering data use, because just having data visible doesn't guarantee that it's going to be used. Work cultures need to change. And all of this is needed to effectively respond to community needs. Next slide, please. So in the next 3 slides, I'll talk very briefly about practical ways that we can build data-driven, client-centered supply chains towards these responsive, resilient, and equitable supply chains. Because without that sense of ownership, without the data, responsiveness and resilience are really hard to build. So the first is we use human-centered design. We design for our clients and with our clients using a methodology that puts creation of solutions for the challenges back in the user's hands. People who deal with problems day in and day out are in the best place to solve these problems. So one of the things we saw is supply chains that reached the port, but that were unable to reach local communities. So this aspect of designing with clients is really critical. The second thing is looking for tools that increase data visibility. We talked about the inability of health systems to be resilient and responsive. That relies utterly on data. We have a tool that reaches community health volunteers called CStock. The other thing is we understand that data visibility is not enough and that teams need to change their work culture and the way they use data to make different decisions locally. And lastly is putting the power of competency and capacity building back in the hands of users. Next slide, please. So practically, what does this mean? When we were implementing CSTOC, it had been implemented successfully in Malawi and mainstream counties in Kenya. When we moved to northern remote counties, we realized that we needed adaptation for the local context. We used human-centered design. CSTOC is now has visuals, it's got audio for low literacy community health volunteers, and it allows resupply even as they're migrating. This is where you get data and you ensure responsiveness and resilience in a supply chain. Next slide, please. Similarly, we use an approach as digital data, as digital transforms data visibility, work cultures need to change so that people can use the data effectively. So we implement impact teams across multiple settings. And some teams happen under a tree. Some of them happen in a health facility. Some happen on Zoom. But the core principle is teaching and supporting communities to use their own data and to solve problems locally, rather than having a cut and paste solution. And finally is putting the solution for the ability to build competencies back in teams' own hand. Next slide. So looking ahead, I want to sort of echo what many of my colleagues have said. Let's try not to look ahead and go back to normal post-pandemic, but really to focus on how can we address underlying supply chain and health system weaknesses that COVID highlighted for us, but that we already knew about. Some thoughts to consider. We have an opportunity to tap into the transformative power of digital, but making sure we do so by adapting these innovations for the context and the clients. Otherwise, they won't work, they won't be used, we won't get the data we need to build these resilient and responsive supply chains. Also to build client-centric supply chains. As we heard from Salim Abdool Karim, the importance of client agency for health is really, really important. And also, as we introduced COVID self-tests and vaccine, let's reconsider the client needs. Where are they going to access those products? How will we get to the supplies to where they're going to use them? Supply chains need new metrics. Measuring cost and efficiency is not enough. We need to be able to measure whether they can withstand shocks, how resilient they are, and how responsive they are to community needs. And that's how we can ensure achieving some of these SDGs. Next slide. Thank you very much for the opportunity to present today.
All right, well, thanks to all of our panelists. I'm Otto Brown. I'm the Dean of the Dalalana School of Public Health here in Toronto, and it's my pleasure to facilitate the panel that we have here today. Look, I'm just going to jump straight into the questions, and this one I think is a question for all the panelists. What is the most novel or surprising lesson that you've learned and applied to manage the COVID-19 pandemic?
I'm happy to go first. And I think for me, what was quite surprising is how receptive the public was to accessing good scientific information from scientists. And our ability to share that through multimedia platforms, I think got translated into mask wearing, which was a rare phenomena. And today it's fairly common because of the trust that was built in scientists speaking to the public.
That's great. And thanks, points to you for going first, Dr. Karim. Dr. Haddad?
Yeah, I mean, I was really surprised. I guess I wasn't surprised, but I think, can you hear me okay?
I can hear you perfectly.
But I think, you know, it just the whole crisis has just reinforced the premium on creativity and flexibility. And you know, GAIN runs programs on the ground. We work with communities, with businesses, with food system people, and I've been really surprised at how we and our partners have been able to keep things going. So we do due diligence on businesses that we are getting finance to, I would never have thought we could do that without going to see the businesses, but we've been able to do it through digital technology and taking photographs and other kinds of validation mechanisms. So I think that's been the big surprise for me, is how creative and how we've been able to make things work.
Chandani, maybe I'll go to you next. I think it follows nicely what you'd like to say.
So Dr. Brown, if I may, if you can hear me.
I can hear you, Zulfi. I'm just going to go to Ms. Chandani for a second. I think she wanted to come in next.
Thank you. Maybe just to build on what Lawrence said, we've been really inspired not only by the creativity, but also by the commitment. We really saw at the time of COVID, when everyone was very strictly locked down, we saw community health workers, we saw our ministry colleagues, everyone really rallying together to try and use whatever digital technology they could to keep things going, to try and make sure, as we saw a dip in essential health services, we would look at the data and we'd say, how can we change this? So just really, really seeing people stretch, even in places where there was no electricity, no power, really stretch to keep those health services going and to figure out how could we extend the services during this difficult time.
Great, thanks. Dr. Bhutta.
So I think the biggest surprise for me, Dr. Brown, has been watching the differences in response between various parts of the world, and particularly in the region where I work in South Asia, to see how communities, particularly rural communities, bounced back very quickly after the initial fear and shock to principally a very stoic acceptance of what was happening, and then very rapid adjustment. So if I was able to create an adjustment and a resilience index, I think rural communities in South Asia that adapted very quickly to the realities would get top marks. And then they would be followed to some extent by the urban slums, where people got together, very rapidly adjusted even things like local supply chains. So, Lawrence talked about how food insecurity loomed large. I was amazed as to how local philanthropy and community support solidarity played such a huge role in ensuring that there wasn't food insecurity at the level that was predicted, that people looked after their neighbors, and that communities stood together. And if you can imagine that these large rural slums and urban slums where people tend to erode, the only way they could have survived is by that spirit, which I think was quite remarkable. And at some stage when the history of the pandemic will be written, people ought to evaluate those differences between high, low, and middle-income countries.
Thanks, Dr. Karim, I might start with you again on this question, if you don't mind. So research and data are critical tools in responding to the pandemic. Would you talk a little bit about tools and really kind of the role of evidence in informing strategies that have been effective in managing the pandemic, despite the uncertainty that we've seen really from the start? And maybe if you've got a minute to talk as well about the gaps in research and tracking or data that still remain.
Thanks very much for that question. And I think I could give you a very long answer. So let me try and condense it to a few key points. And I think we heard repeatedly in the talks today and previously the importance of measurement. And when you measure, you're able to monitor progress and whether you're making a difference or not. And I think in the case of COVID-19, the key measurements are really about the infections, it's about who's being hospitalized, and it's the deaths. And those three measurements depend on strong information systems. And I think Yasmin mentioned, particularly in Africa, these are very fragile. So you're trying to monitor the spread of a virus that's spreading at a speed that is quite unprecedented against this backdrop. So one of the big challenges we faced was around, besides the fragile health information systems, was trying to strengthen testing and try and test as many people as possible. So, and that's important because of the asymptomatic, the size of asymptomatic infections. But the first hurdle we encountered was our ability to procure tests. And these tests are all being produced outside of Africa. And so Africa had to join the global queue, and you can see who was waiting for the crumbs. So although we set up the infrastructure to do the testing, we built the capacity very rapidly to enable, going from nothing to something like 50,000 tests a day, I think 100,000 at some stage in South Africa as an example. We suddenly were facing reagent challenges. We're suddenly facing kit challenges. And so then we had to rationalize who we were testing. And so we moved from more wider testing to looking at who's being hospitalized and prioritize saving lives over the public health imperatives. And then the other issue was around the deaths and trying to attribute deaths to COVID and taking into account how people were voting with their feet by not going to health facilities. So let me stop there, but just to underscore the importance of supplies for what you need, strong health information systems. These can't be built in a state of emergency or disaster and so on. It needs to be the investments we make upfront and build on those. Thank you.
Thank you. Chandani, data must be critical to your entire operation. Do you want to talk about the critical sort of gaps in data or data tracking that remain, or things that should be bridged?
Yeah, so yes, you know, it's very hard to operate a supply chain in the absence of data. Yet many countries do. We use proxies, we use very imperfect data. But, you know, the biggest gap, I think, as my colleague just said, the most important thing is that you can't build those data systems in the middle of an emergency. These are things, and they're not easy to do. It's very easy to say data is a really big gap. But really, if you want to have a resilient and responsive supply chain, if you want to be able to procure the test kits and even the supplies that you need, you really need to understand end-use data. So that means for every, you know, a supply chain can't extend until the port and stop there. It needs to extend down to the last community health volunteer, down to the last health facility. And you need client-facing data that helps you run your supply chain. And you need that data to flow fairly quickly to decision makers at all levels of the supply chain. And you need the data to be usable. So data is critical, and that's why I really made such a big emphasis about it. On the plus side, I think there are so many, digital is transforming who and how we can access data. If I were to tell you that we can get data from Mandera and Wajir, these are very marginalized communities on the border of northern Kenya, and we've found a way to do it without continuous connectivity. So we're very fortunate to be living in a time where there are tools that can help us collect the data, but it does require policy that makes that a priority, and it requires investments and an understanding of why that's so important.
Right.
Thank you.
Dr. Haddad, you talked about, you know, just seeing the tip of the iceberg now. Is there data and research that's really going to be critical to informing about how we make sure that this isn't the sting in the tail?
Thank you, Dr. Brown. Well, you know, when this whole thing really landed in March, we didn't know what was happening. We were flying blind. All our programs, our country offices, all of our partners. What's happening to food prices? How many people are missing meals? What's happening to the quality of diet? And I was shocked at how threadbare our systems, our emergency systems were, because the current emergency systems in food are usually responding to something that is an emergency, but we have usually a kind of a 2 or 3 month foreboding that it's going to happen. We've got warning this is going to happen. There's going to be a bad harvest. But this crisis hit overnight. And so our systems were really poorly equipped. So I talked about how COVID-19 has sort of taken us back 10 years, but it's a bit like a time machine because it also takes us forward. And I think, as Yasmin said, the digitalization of data collection, I think this is now going to be pushed forward many years into the future very quickly. So now we've come up with systems working with partners where if we want to know how many of the the wet markets in Addis Ababa are open and functioning. Of the hundreds of them, how many of them are open and functioning? We don't do a survey. We can now put out a call via an app, and we can recruit enumerators within 2 days, screen them within another day, and have some results back within a week about which markets are open and which ones are not. It's not much more expensive, if at all more expensive, than the more conventional techniques. So COVID-19 has taken our data collection from the 20th century into the 21st century very quickly.
I'm going to maybe just switch gears slightly and build off of this line of questions for Dr. Bhutta now. Dr. Bhutta, do you see a way that preparing for the SDGs could have impacted COVID-19 response in a positive way, whether it be on the data, the research, or even the other elements of infrastructure that went into it?
Oh, absolutely. I think the SDGs offer a very interesting framework for analyzing how countries have done well or not done well in this COVID pandemic, and what are the lessons for the future. So I entirely agree with the panel that investing in basic information systems is extremely important. And many countries were able to capitalize on what they were able to implement. Pakistan, for example, used the polio surveillance network to get the best data that they have on COVID to inform policy. But my favorite example, Dr. Brown, is that of Sri Lanka. And I've been studying Sri Lanka. People have talked about exemplar countries in COVID, largely high-income countries like South Korea, Taiwan, Singapore, that have done very well. But they don't talk about countries that have done extraordinarily well, who don't have those means and resources, such as Cuba, such as Sri Lanka. Sri Lanka has a total case fatality mortality number from COVID of less than 20. And how was it able to do so? It was able to do so on the basis of a phenomenal primary care system that exists, that not only collects the information, was able to build on the investments made over the last 50 years or so in education, in building an egalitarian, equitable network of services, where if you go and see how services are provided, how care seeking takes place, and how compliance, very importantly, compliance with many of the preventive measures such as use of masks, use of sanitation, use of hand washing, all of these, which are big hurdles apparently in high income and some middle income settings, have been relatively easy in systems that were prepared for this. And they were prepared for this because they had invested already in the basics, in education, in providing services, in ensuring that there was not tremendous inequity within the population, and also that their services were geared to the provision of a basic primary universal health care and coverage, which is, I think, the principle of what we need to follow in the SDGs. So to summarize, I think the Sustainable Development Goals are an example of how multi-sectoral investment across various sectors, ranging from agriculture, food security, social safety nets, gender equality, education, and high-quality systems dealing with environment, water, sanitation, and hygiene, are critical to how we deal with some of these challenges. And as I said, we have exemplars from countries that have done so much for so little.
Dr. Haddad, maybe I'll start with you for this next question. And it's really about supply chains. And Chandani, I'll go to you next on this as well. But Dr. Haddad, supply chains have obviously been disrupted terribly by COVID. But are there successful examples that you would sort of call to mind that actually can help us think about how we transformed traditional supply chains or more conventional supply chains anywhere in the world, and whether it be about food or personal protective equipment or even drugs?
Sure. Well, there are lots of examples from the 9 countries that GAIN works in. And I think in general, I'm seeing supply chains, food supply chains becoming shorter and less reliant. And when I mean shorter, I don't just mean geographically shorter, I mean temporally shorter. Often there's a massive gap between when something is harvested and when it's sold. So I think we'll see them become shorter and less reliant on sort of just-in-time forms of business, which are like a house of cards, really. When a gust of wind comes along, and COVID is more like a hurricane in the middle of a typhoon, or typhoon in the middle of a hurricane. When a gust of wind comes along, those house of cards systems just collapse. So I think we'll see shorter supply chains, more diverse supply chains. I think we'll see more staple crops will be more fortified. We'll see fortification of staple foods, getting micronutrients into those foods is a kind of a no regrets thing to do when fruits, vegetables, animal source foods are becoming so volatile in their prices and their availability. I think we'll see that. I think we'll see a big push. We've seen a lot of solar powered cold chains and cool chains for perishable foods. That has been accelerated. We're seeing that in lots of our countries. And in a lot of our countries, we're seeing a big push for new forms of finance to small and medium enterprises. And the small and medium food enterprises are becoming much better at getting investor ready so that they are able to avail themselves of the new finance. So all of these kinds of adaptations and evolutions are happening at a very rapid pace.
Yeah. Chandani?
So I've been trying to think. So we have positive examples, probably for PPE. I can share some examples where I think as soon as it became clear that A, global supply chains were not working, and B, PPE was a critical, especially masks and PPE locally was such a critical supply, we saw very quickly in Kenya the private sector pivot and start to manufacture these themselves, knowing that necessarily these could not be imported. So those were examples of where the private sector stepped in. In a low to middle income country like Kenya, this is feasible. In other countries where manufacturing and industry is not as strong, obviously we haven't seen that. There are also a couple of other examples to share, maybe not such a positive one, unfortunately. Supply chains are inextricably linked with services. And one of the things we saw, as we mentioned before, is a real dip in access to essential health services. One of the examples to share is reproductive health. We saw a real dip in people accessing family planning, reproductive health. And then as we started to look at the data with the national program, we've seen a rise, a really huge increase in teen pregnancies. So this points to really where the disruption has created long-term impact, where you have, unwanted pregnancies amongst teenagers as women of all ages. Having said that, I think where we have seen positive signs is when perhaps the health-seeking behavior has changed from the public sector to the private sector. The pharmacy tends to be the first point of call for many Kenyans. And we saw that happening, and we saw pharmacies begin to quickly put in place delivery systems so that people didn't have to go to pharmacies to get what they needed, but instead using a delivery and an online system. So I think we've seen adaptations happen. They don't necessarily reach the most marginalized, but we have seen some positive responses locally to some of the supply chain disruptions.
Great, thanks. Look, I want to maybe shift gears a little bit, and Dr. Bhutta, I'll come to you first on this next question. So the pandemic has thrown a pretty good spotlight on the crisis of trust in governance, whether it be at a local or an international level. And there is this hope, I think, among many of us that trust in governance, at least trust in expertise, I should say, is increasing in the COVID era. So what about trust in those who are kind of setting and enforcing the rules? And because they depend so heavily on expertise and innovation that we've been talking about already in this panel, would you like to talk a little bit about what we can learn about building trust in government health messages, even when there may be relatively little trust in the governments themselves? And maybe the SDG experience, again, throws a light on all of this.
So Dr. Brown, that's a fantastic question. And it's a question that I recently explored because I looked at COVID response across the Islamic world, the 40 plus Muslim countries, in terms of how they had responded. And what appeared, it's just been published in the Eastern Mediterranean WHO journal. And what emerged from it is that the best responses that we had seen in terms of the flattening of the curve by June, July this year was not in the autocratic governments or the authoritarian governments that were able to implement their will immediately or enforce lockdowns in a very strict curfew-like way. The best responses were their democracies, and the democracy index of those countries was high, and they were able to enter into a dialogue with civic society and be able to negotiate an adaptation and application of some of those principles in a much more acceptable way. And Francis Fukuyama has said the same thing in looking at the response in North America, that without civic society engagement and without faith in governance and good governance or good science, it is very difficult to implement something which requires such a lot of community participation. So to answer your question, the SDGs were coined through a very participatory process, but in a different time, in a time where we did not have the challenge of the global pandemic. But in looking back, a lot of the principles of the SDGs are such that governments that do have a compact of trust, a compact of good governance, a compact of accountability with their people are best placed to address this in the medium and short term. To ask people to make sacrifices, to ask businesses to make sacrifices, and to ask people to change their lifestyles is only possible when you have the trust of the people. So on the one hand, we have the need to rebuild the trust with science, with public policy, but also with governance systems. And it's just as true for low and middle income countries as you know, is true for high income countries.
I wonder if, Dr. Karim, if you had something you wanted to speak to on this. You talked about the challenge of trying to deal with public health when it's essentially overwhelmed in fragile systems.
Yeah, and I mean, my points are not too different from Zulfi's. You know, the importance is really about an informed public. And I think that in countries, even poor countries, part of the resilience comes from facing adversity. And so a new epidemic, in a way, is not, it's just another challenge that you've had to face. But I think where you have distrust in governments, your ability to respond is different. And in fact, what I see is a way forward in terms of the impasse you have where governments are not trusted and are established in ways that are undemocratic, for want of better terminology, then the voice of scientists becomes really important, and demystifying science to the public and helping them understand the scientific method so that they're able to differentiate between what is fact and what is fake, I think creates the supportive environment for more evidence-based decision-making and more trust in science in terms of decisions being made about their lives. And that I've seen in South Africa and several other African countries. Thanks.
Chandani, maybe I'll turn to you because you're navigating a space between governments and civil society, communities everywhere. Did you want to talk a little bit about how we kind of make sure there's at least trust in the types of messages that need to be put forward?
I think I agree with what my colleagues have said, is that, you know, it becomes when there are questions about the government and perhaps a lack of trust in governance, I think not only the science, but actually the approach makes a really big difference. So I've seen one of the benefits or one of the positive signs we've seen in Kenya is much more ownership at the local level. Kenya's becoming highly devolved. It is a highly devolved country, and devolution continues to take root at local levels. And having local partners and local county governments come together using science to sort of help communities, community health volunteers go out into the community, that personal touch and that local approach seems to be making a really big difference, even as you see bigger questions with the government and you know, whether or not the information is reliable.
Let me build on that right now, and I'm going to just maybe steer a little bit in a new direction. So this is a critical issue of how we're engaging, how we're communicating, all the sort of critical aspects of that. Would someone want to talk a little bit about how we can get public health professionals and all the people they work with to improve their communication strategy so that they are able to, regardless of the trust in government, able to keep that strong communication and that role of expertise just critical and credible and valuable and valued. So communication strategies. Dr. Haddad, please go ahead.
Right. I mean, I think there are lots of very lots of very basic things you can do. I think the most basic thing is to try and put yourself in the position of the person you're trying to communicate with and really try to understand how do they process, how do they receive information, and how do they process information. And so I think we as public health professionals and researchers are very good at talking to ourselves and very good at communicating within our bubbles. But we need to be much better at communicating the sometimes very complex and nuanced messages that come out of our work. We need to practice, and we need to practice with our friends and our families and people who don't think about this stuff ever, really, unless we talk to them about it. And when we can effectively communicate to them using imagery, using our right brain as well as our left brain, then we're really onto something. And then we really begin to have a dialogue rather than sort of simply monologue. So I think that's a big part of it.
Good. Dr. Bhutta, do you want to respond to this?
So Dr. Brown, one disappointment that I must say in this entire last 9 months or so has been the failure on the part of many political leaders in terms of embracing the truth and science. And without naming names, I think the one disappointment that I have in that process is that a few institutions of excellence or public health leaders have found it difficult to raise their voice because of political exigencies. And when, again, the dissection of all of this is done, we would need to explore as to why that happened. Why didn't an agency A or B or C have the spine to stand up and call out absolute lies and things that have cost thousands, if not more, of lives because of misinformation or because of actually challenging the truth out there? I've seen this happen in more than one place. And I think when we do look at the future in terms of what we need to build in terms of resilient health systems, I think we need to build resilient public health institutions that ought to have the autonomy, the firewalls around them, so that a politician in power or a government in power ought not to be able to influence the truth coming out and hence cause enormous damage in terms of public confidence in some of our institutions. I think that will be a long-lasting tragedy if that were allowed to continue without necessarily some remedial measures that need to provide that level of assurance and guarantees as we move on, that science is above politics, that truth is above politics, and all of those measures, if they are not protected, actually cost lives. And they don't not only affect one nation, they affect a region and they affect the globe. And this is something I hope that there will be some active debate on, and people will stand up and speak the truth as to what we need to do in the future to help safeguard our public health institutions.
Thanks, Dr. Bhutta. Okay, maybe I'll take us to a slightly different sort of question now. And this is one of the most popular questions from people attending today. So what are the key skills? We talked about communication already and the critical role of communication. But what are the key skills and perspectives that aspiring professionals in public health should focus on as they try to, they begin to imagine a career confronting and addressing global health challenges? But now in this age of pandemics, technology, globalization, and building on the last question, a little bit of mistrust as well in centers of expertise and in governance mechanisms. What are the people who are actually going to respond in the next pandemic? What do they need to be thinking about? Dr. Karim, you want to start?
Sure. So a couple of points. I think the first is, and it's not necessarily for public health, but I think as scientists, we have certain roles and responsibilities in society. We have freedoms that come with our ability to explore new terrains. But with that, what are the matching responsibilities? And I think communicating our findings, not only through peer-reviewed publications and conference presentations, but to those who would benefit from the findings, whether that be decision makers or whether that's the public who could benefit from it. So I think that's an important part. I also see communication as a process. So you have to start building relationships with potential beneficiaries of your research right up front. You don't wait for a disaster and an emergency to start to do that. I also think that in thinking about this, it's building that trust that takes a lot of time, that sometimes one has differences of opinion, and differences of opinion is to me, it's part of the scientific discourse, but how do you share that with the public? So when you see it, when you have differences of opinion, they know how that needs to be managed. But I think my last point around public health and the practice of public health is really about how do we use digital spaces more and communication space? So we can't be everywhere, all of the time, but there are many opportunities that now that we can utilize to be able to share knowledge. And the more we share that knowledge, the more accessible it is, the more we can move towards evidence-based decision-making and trust in public and trust in everyone. Thank you.
Dr. Haddad, anything to add to that?
I mean, there's three things I'd like to emphasize. I think the first thing is we need to, we in the science or the NGO space, the evidence space, we need to speak truth to power. Speaking truth to power is a sacred obligation that we all have. Unfortunately, it can be incredibly inconvenient if we are funded by an agency that want to change their behavior. That's very difficult. But nevertheless, I think we have to firmly and creatively. That's the first thing. The second thing is, this is going to sound slightly strange, but we have to read widely. Early career professionals, all your incentives are to dive deeply into your subject, to get published, to get tenure. That's important, but you have to read widely. You have to, read The Economist, read New Scientist, read these journals read Nature, read these broad journals. It's important because it'll help you contextualize your work. It'll help you communicate to people who are not as deeply immersed in the subject as you. It'll help you connect with the members of the human race that you sometimes don't talk to when you're in your departmental debates. And I think the third thing is be human. I mean, admit mistakes, be authentic, show vulnerability, develop relationships. Even don't develop transactional relationships only, develop relationships. You're in a career ascent. Be nice to the people you're encountering on your way up, because I think, as Oscar Wilde said, you'll probably encounter them on the way down. So that's my advice. Speak truth to power, read widely to contextualize your scientific specific work, and be human.
That's great advice. Ms. Chandani, last word to you before we close off the panel. Any advice to
Honestly, I think Lawrence Haddad said it so well. I was going to say the point he made last. It doesn't matter how bright or how well qualified you are. If you can't connect to other people, if you can't relate and inspire trust through who you are, no one's really going to take the advice you have as a public health professional. And you're not going to have the empathy to be able to translate that best practice to wherever it's needed. So I think, thank you, Lawrence. That was really well said.
Great. Well, let me add my thanks to, I know, everyone who's listening in for a really excellent panel and working through this Zoom world of talking and having a discussion this way. I really appreciate it. It's a great question for us to end on. And although you can't hear an audience clapping and smiling, I'm hopefully can at least see us all doing it virtually. With that, I'll say thank you and turn it over to the next round. Thank you very much.
Thank you.
Thank you.
Thank you to that wonderful panel. And next up, we have another of my heroes. Dr. Swaminathan is a formidable scientist and the chief scientist at the World Health Organization. I can only imagine how little sleep has taken over the last 9 months. So we are very grateful for the time that she's taking today to provide reflections on the lessons that the coronavirus pandemic is teaching us. Dr. Soumya, over to you.
Thank you. Thank you so much. And wonderful to see all of you and hear all of you. What I'm going to do is get right into my presentation and just share some of the reflections and learnings from the last 9 or 10 months, really, from having been at this, I suppose, this viewpoint that I've had sitting here at the WHO. Never imagined in my wildest dreams that I would be at the WHO as the chief scientist in the middle of a pandemic. And it's been challenging, but it's really been a humbling experience as well. And before I start, my warmest and deepest congratulations to Salim and Quarraisha for this extremely well-deserved award that I'm sure everyone around the world agrees with, for the amazing work that they have been doing, the leadership and the role models that they are really for many people around the world. So I think I'm going to have to request someone to change my slides. Just starting with the global epidemiological situation very quickly, we are still in the exponential phase of this pandemic, somewhere between 350 to 400,000 new infections a day. And these are just the known and diagnosed new infections. And anywhere between 4,000 to 6,000 deaths a day. It fluctuates a little bit. And you can see the different WHO regions colored differently on this graph here, with yellow really being the region of the Americas, where we've seen for the last several months the major share of new infections, followed by Southeast Asia, and then now the European region. And you can see on the right-hand side the countries which are the ones that have the largest number of new cases every day. Next. This one is just a sort of a population standardized. So it's cases reported per million. The darker the color, the higher the number of cases per unit population. So again, the region of the Americas, Europe now, Russia, and then parts of India, Southeast Asia, and parts of South Africa, though that's getting better. Next. And again, this is COVID deaths. This has really varied widely between regions and countries, and it's been quite, something to think about as to why case fatality rates in Africa and Asia, Southeast Asia particularly, were so much lower than case fatality rates in Europe and in the Americas. And there could be many reasons for that, which we can discuss later. Next. On the next slide, we see what's happened really from the beginning. Different countries have followed different trajectories or patterns. China is a good example. It all started there, but completely under control now. There are other countries, again, in the East Asia, where they've avoided large outbreaks. They've acted early and fast, and they're able to contain the clusters before it sort of spreads into massive community transmission. Then we've got Europe, major outbreak brought under control, not having eased restrictions, seeing a resurgence, and then intense transmission continuing. And again, there are several countries that are in that phase, which really haven't turned the corner. These are mostly the large countries and those that have had difficulties really containing it. The next slide, and the next. To start with, perhaps a word on health systems. We've seen huge stress on health systems all over the world, lack of supplies. In the beginning, it was such a constraint, not having the PPEs, even the basic gloves and masks for healthcare workers. Huge burden, disproportionately impacted. Healthcare workers are about 2 to 3% of the population of most countries, but have accounted for 10 to 30% of infections and a substantial proportion of deaths also, unfortunately. And on the health services, I want to show you on the next slide, the results of a pulse survey that the WHO did looking at health services. While most countries had defined essential health services package and had also identified a core set of services, next slide, what actually happened was that most countries reported disruptions, either partial or complete disruptions across these 25 essential health services, starting with immunization and then going on to things like non-communicable disease diagnosis and management, including cancer. A lot of cancer patients have suffered, malaria, bed net distributions, TB. We saw huge drops in TB notification, but also emergency surgery, blood transfusion, so huge impact. Next. And various countries use different approaches. Some of them went into triaging, like Thailand, telemedicine deployment. India has used telemedicine in a big way, so have other countries. Task shifting, looking at other ways of doing supply chains. TB patients, were being dispensed drugs at home, or NCD patients for that matter, for several months at a time, and so on. Removal of user fees by a few countries as well, which of course helped. Next. Digital health, has really come into the forefront, and I think there's an opportunity here to really leapfrog telemedicine, as I mentioned. The platforms like ECHO, which are global learning collaborative platforms, have been used traditionally to train healthcare providers. These are being used massively now for outreach. Many countries are now thinking about quickly shifting to electronic and portable health records. The WHO has been working with a number of large tech companies, and we've created the Digital Health Clearinghouse, which is, it's just a pilot or a mock-up now, but essentially would connect ministries of health with providers of digital health solutions eventually. Next. And this is just a picture and an idea I want to share with you about shared medical appointments. This has been used by the Mayo Clinic and many other hospitals, I think in Canada, across the US and UK. So the shared medical appointments essentially reduce time for the doctor. They increase the interactions between the patients and the doctors. They can be used for diseases where there's no confidentiality issues. Here's a doctor at the Arvind Eye Hospital in Pondicherry talking to a group of glaucoma patients. And they actually did a randomized clinical trial, which is yet to be published, but shared some initial findings which showed both benefits for patients and benefits for providers. So I was wondering whether we could take a step forward and really look at virtual shared medical appointments where you're at a distance and doing telemedicine, but connecting with many patients at the same time, perhaps from different places, sitting in their own homes or sitting in different clinics. And this is something that's been piloted in Pakistan for a completely different reason, because women doctors there are not allowed to go out and work. So once they get married, these women are unable to practice their profession. And so there's a young woman entrepreneur who started this remote consultations through telemedicine where the woman doctor is at home, but a healthcare worker is out in the community, and then the doctor is able to provide care. So if you do it virtually and you do it shared, perhaps this is a way of sharing very limited specialist resources in most of the lower middle income countries. Next. But this needs to be tested and tried in more randomized trials. So we've been talking to countries and sharing experiences on a weekly basis. This is one of the things we do. And we have a number of countries that have sort of become exemplars, really. Again, a number of countries in the Southeast Asia region reacted very quickly. So Thailand, South Korea, Hong Kong, Singapore, New Zealand, Taiwan, they acted quickly. They had experience from SARS-1. They had strong public health cadre laboratories and people who actually trusted and obeyed, or at least obeyed the government instructions. So they were able to put in place contact tracing, quarantining, they put in travel restriction very early, did a number of things which some of the high income countries actually could not do, perhaps because they've underinvested in public health systems and overinvested in tertiary care hospitals. So again, this will come back to lessons for the future. Next. Again, WHO has been in the center of doing evidence-based policy. The amount of publications really is huge. We're having to review a large number of not only published papers, but also preprints. And we've been able to step up and we have a huge database now that's growing every day and about 4 to 9 million downloads every month. This has gone up a lot since the pandemic started. Next. We've had to, so this is just a picture to show all the policy and technical guidance that we're constantly updating. And we do all of this through convening expert groups. And we have regular calls with the global health leaders. with our regional and country offices. Next. So this, a good example is sero-epidemiological studies. We put out very early on core protocols, the Unity set of studies and the Solidarity 2 set of studies that countries could just adopt and use. So it was a question of the design of the study, but also of standardizing the laboratory assays and the reagents that are used. We now know of at least 140 peer-reviewed publications and many more informal reports. Most study results suggesting less than 10% seroprevalence. But again, with notable exceptions, so data from South Africa, from India, from some of the countries which have these urban high density areas have been showing very high seroprevalence rates of anywhere between 40 to 60%. And we're learning more and more, of course, about the epidemiology of this disease. But on the average, we can say about 10% of the world's population has probably been exposed and infected by SARS-CoV-2. Next. I want to spend a minute on the whole genome sequences, because this has been such a very notable and astounding thing that we had the first genome sequences published on the 11th of January in GISAID, and now we have, I think, 160,000 or so in this database. And the idea really is, on the next slide, yes, you can see the rate at which the depositions of these whole genome sequences in this database called GISAID, 124 countries, real-time data sharing. I think this was about a week ago that we had 140,000 whole genome sequences. And in the gray at the bottom of the graph, you can see GenBank, mostly duplicates of what's in GISAID. So we need to also ask ourselves, what's incentivizing scientists to share in this database, and how do we leverage this for other diseases, other pathogens? Next. And the sequence data is important for a number of reasons. I don't need to tell this audience, to do diagnostic tests. We had within 48 hours the first diagnostic kits that were prepared, potential drug and vaccine targets, allowing the analysis within countries of how cases came in, what were the importation events. So New Zealand, the UK, many countries have actually looked at how many importation events they had, use it for contact tracing, identifying clusters, and then making sure that it hasn't drifted to significant strain differences. And then, of course, ultimately tracing it to animal precursors. And because of the similarities, we know that it probably came from bats, and that there's a high degree also of concordance with the pangolin coronavirus. But we still don't know what the root was and whether it actually came from bats through some intermediate animal into humans. Next. And GISAID was set up more than 10 years ago, basically to share influenza sequences, but they were very quickly able to set up a platform and requested by the Chinese scientists, and they were able to put in place this one. So they were ready for disease X, and I think this is what we need as a global community, need to agree on what kind of platforms we're going to use in the future. Next. Quick words on therapeutics, diagnostics, and vaccines and what we've been doing. Let's go to the next slide, please. The ACT Accelerator, I won't spend a lot of time, but this is where WHO has brought together all the global players in the development, accelerating the development of diagnostics, therapeutics, and vaccines, but also ensuring fair and equitable access. We have, of course, a huge number of vaccines in development, but the most important thing is today we have 188 countries and economies representing 7 billion people around the world that have joined the COVAX facility. And I think this, again, is unprecedented, and it shows that most people do want to work together collaboratively and in solidarity. Next. So again, diagnostics has moved really fast, with the first genetic sequences being shared on the 11th of January and the ACT Accelerator being launched in March. But today we have not only a lot of tests being procured and distributed across, but also the development of rapid antigen diagnostic tests. Next slide. We started with the RT-PCR tests, which are difficult. We had only 2 countries in Africa, for example, at the beginning of the pandemic, Senegal and South Africa, that had the capacity to do these tests. Today, most countries do have at least 1 lab, but it's still not good enough to really do a lot of testing. So the antigen tests really are a game changer. Today, we have 2 tests that are pre-qualified, that have high sensitivity, over 97%, high specificity, and then a number of antigen detection tests, also point of care, which can be used for these seroepidemiological studies, and of course not useful for acute patient management. Next. And antigen tests are useful because they will detect those who are at the height of their viral load in the respiratory secretions, or those who are most contagious. So quite useful for cluster investigations, outbreaks, and for screening people who are living in closed settings. So we have some guidance out on where these should be used and where they should not be used. For example, in airports, these would not be useful because your prevalence of the infection is going to be so low that you'll get too many false positives. Next. The Solidarity trial results, I'm very happy to say, were just out on medRxiv, are under submission to the New England Journal. And very quickly to show you the results, the headlines next. This was, of course, a global trial and adaptive design that initially we started off by testing these 4 repurposed drugs, next, across 30 countries, over 400 hospitals, hundreds of principal investigators. Today, it's the largest trial in the world with over close to 13,000 patients now included. Next. And unfortunately, the results were disappointing because none of the 4 drugs we studied showed any benefit either on mortality, on the duration of hospitalization, or on progression from being not on ventilation to being on ventilation. And particularly, there was a lot of hope around remdesivir because that's a really antiviral drug that we thought might have some effect because of the early experience. But unfortunately, on these parameters and in this group of hospitalized patients, it did not reduce mortality or progression of disease. Next. Perhaps it may work better earlier on, but not in this group of patients. So we also did a meta-analysis of the published remdesivir results, and you can see that the relative risk was 0.9 with a confidence interval from 0.8 to 1.05. Next. On vaccines, again, totally unprecedented, astounding, the fact that the first vaccine went into phase 1 trial within 3 months of the sequences being published. Normally, vaccine development takes anywhere from 5 to 10 years minimum, but here is how we're trying to accelerate it by moving very quickly from phase 1 into phase 2 and then into phase 3, and the most importantly, investing in manufacturing even before the phase 3 trial results are available, and preparing for deployment and delivery in countries. So all of this is happening through the COVAX pillar of the ACT Accelerator, and WHO obviously playing a big role both on the normative side, on the policy and the strategy, but also on the regulatory or the pre-qualification, and helping with the R&D as well through a Solidarity vaccine trial that we are proposing, again on the same kind of a platform as the Solidarity Therapeutics trial. Next. So we have 10 candidates as of now in phase 3 trials. A number of them are from China, but also from Janssen, from Moderna, from Pfizer. We have 2 RNA vaccines, the Moderna one and the Pfizer one, which are in advanced stage of phase 3. We have a couple of viral vectors, the AstraZeneca, University of Oxford one, there's a CanSino, and then the J&J, and then a couple of inactivated viruses. So the good thing is a number of different platforms. So hopefully several of them will prove to be safe and efficacious, and we should start seeing results late 2020, but more likely early 2021. Next. So I think we'll go to the next one. On ethics, we've had a very active bioethics working group that's been deliberating and coming up with a number of documents and papers on both on identifying principles around research, like the human challenge studies, for example, but also providing a framework, a values, an ethical framework for allocation of scarce vaccines and scarce diagnostics, for example, and also on things like the ethics of contact tracing apps, of AI-based applications, immunity passports, and so on. Next. So I want to end very quickly with the findings from the global burden of disease that we've all seen come out this week in the Lancet. We've made a lot of progress in maternal and child mortality, but we see that there's a rising exposure to the critical risk factors related to non-communicable diseases. Next. And gaps, I think we're all aware that health systems are really not prepared for the rapid rise in NCDs, that public health has failed to stop the increase in risk factors. We focused on the delivery of health services, but not really on tackling the wider determinants of health, going upstream really to look at what those risk factors are. And the pandemic today raises us a lot of questions about the direction of global health, and it's clear that we need to pay more attention to all of the other factors, including the factors related to the social, environmental, economic, and commercial determinants of health, including, of course, a lot of attention to income, to education, and fertility rates, which again relates to women's education and gender equality. Next. And Richard, I think, said it very well about not being a single coronavirus, but really the combination of three epidemics: the virus, the chronic conditions that make people more susceptible to it, and a situation of deepening poverty and inequality. And we've seen that the pandemic has exposed inequalities and inequities in countries around the world. Next. So I think I'd like to conclude by saying that, if we're looking ahead, governments need to see that every sector needs to be involved, not just in outbreak response, but also in addressing the issues around that determine people's health. That communication of information is extremely important. And we've seen the countries that have done well have had transparent and regular communication from their leaders, both political leaders and public health leaders. Communities need to be engaged from the very beginning. Again, a success of countries that have done well have been communities that have engaged and that know what they need to do and why they're being asked to do certain things. And I'm not talking about infodemics today, but again, that's been a huge issue really of dealing with rumors and miscommunications and really needing the social and behavioral scientists to be engaged from the very beginning. Next. Thank you very much for this opportunity, and I look forward to further comments, questions. Back to you, Kali. Thanks.
Thanks so much for a wonderful presentation, very stimulating, and I know we will come back to it in the next segment for the discussion segment. So thanks so much. From the global picture and the lessons about how to transform the public health systems in the countries, we bring up now next is to the level of governments and personal experiences, two exceptional leaders who will speak to us about this. They are researchers at the core, they're all, and among IDRC's former and current grantees. I'm very I also want to particularly thank Dr. Nishtar, who has been here after having tested positive for COVID-19 this week, which undoubtedly makes this all the more personal for her. Really appreciate your being available for us today. Our speakers, Dr. Sania Nishtar and Cleopatra Mujini, will both be presenting individually on their work, and then will be joining Rupa Dutt, Executive Director and Co-founder of Women in Global Health, for a discussion alongside Dr. Salim Abdul Karim. Dr. Nishtar is a special assistant to Pakistan's Prime Minister and Federal Minister, Poverty Alleviation and Social Safety Minister, Government of Pakistan. She will be speaking to us about Ehsaas, emergency cash, digital transformations within government in the COVID-19 context. Cleopatra who's the director for Africa Regional Office, International Center for Research on Women. She will be speaking to us about Nowhere to Turn: Youth, Sexual and Reproductive Health, and Gender-Based Violence during the COVID-19 pandemic, which will bring the also important gender dimensions to our discussion about COVID-19. Thank you so much for being here. The floor is yours.
Well, hello, everybody, and good day. I want to begin by thanking you for asking me to be part of this conversation, and my apologies for not switching on my video. I'm convalescing currently, and I'm not as nicely turned out as all of you. All of you know me as somebody who belongs to the health sector, but in Pakistan's cabinet, I'm responsible for social protection. And therefore, I was part of my country's efforts to protect both lives and livelihoods. It is with great humility that I say that our country did very well, and we are very honored that the world is acknowledging it now, but this is not the time to be complacent, and the government is fully cognizant of that. So let me give you a quick snapshot of the huge program of digital payments that was made whilst we had a surge and whilst the lockdowns were in effect. But before I do that, let me just sidestep. Next one, please. When I used to work in the health, next one, please. When I used to work in the health sector, I always used to wonder that there are so many technological solutions, and I won't have the time to go over each one of them, but they're illustrated on the slide. You know, a woman can take her, can basically monitor herself, a woman with chronic disease. She can throw her data up on, up to the cloud. It's possible to secure those electronic health records on a blockchain. It's possible for automatic AI-enabled alerts to be triggered, for a doctor's appointment to be booked, for an Uber to be ordered. It's entirely possible for the doctor to test things on a laser twin, and then for polypills to be printed at the local pharmacy using additive manufacturing technologies, for medicines like insulin to be delivered through a drone. And I often wondered why all these things are commercially available, but they're not gelling together. There are no incentives for us to piece these together in the health system. And when I actually went to the other side of the fence to social protection, I realized that the solution to these is digital payments. If we institutionalize digital payments, we can actually deliver a totally automated health system. But that's not the subject we're discussing today. Next one, please. The subject that we are discussing today is about, and I'll go over it very quickly. When the lockdowns came into effect, the context in Pakistan was that there were 24 million breadwinners, either self-employed or daily or piece rate wagers. Life for them came to a standstill. They have 160 million dependents, and they were in acute distress. The country was practically on the verge of civil unrest. So the cabinet entrusted my division, my ministry, with the responsibility to disperse an emergency cash package to 16.9 million families. Over $1 billion were committed, and this would allow us to reach out to half the families in Pakistan. This was the largest social protection program ever in the history of the country. And it was a massive operation. It was going to take place in the most difficult circumstances. Next one, please. There were basically three things that we leveraged because we were quite fortunate in having started work on a multi-component, a multi-dimensional whole-of-government program aimed at poverty alleviation a year ago, called Ehsaas, which is the Urdu word for compassion. And the 140 policies, strategies, programs, which are part of Ehsaas, are linked by theory of change. And we invested a whole year in developing the institutional architecture to roll this out properly, in addition to the programs that were incrementally being piloted and scaled up. Relevant to the discussion were three pillars. There was a new biometric payment system, which verified payments in real time, which we procured and brought 2 commercial banks on board in 2019. There was an SMS, a demand-side SMS-based assistance-seeking mechanism, and we did increasing war games to perfect it. And so that technology and that know-how was there, and then a new profiling data analytics mechanism, which we actually developed and tested and deployed in 2019. So we pulled a thread through all these three things to run Ehsaas emergency cash. Next, please. What we did was such that we heavily advertised and asked people to send us their 16-digit national identity card numbers on an 8171 short code. Once the messages arrived, we ran them through different databases, and automatic messages generated at every level. And then people who were eligible were asked to go and collect their payments, and payments were made at over 2,000 campsites all over the country. There were a number of wealth proxies that we used for exclusion, and we also used our survey data, but we couldn't rely entirely on survey data because it's 10 years old, and currently our efforts are ongoing to update it. Next one, please. We received a total of 181 million requests, of which 66 million were unique. Next. And then payments were staggered, so we didn't ask everybody to go collect payments the same day. And a simple SMS would come asking people to go to the payment site and collect their money. Next, please. So this was a very profound experience, you know, the fifth most populous country in the world, diverse federal polity. And here they were, these people going and collecting cash in a very transparent, apolitical, rule-based manner from campsites. And it really helped to further trust between the governments and its citizens. Next one, please. We just did a pulse survey, a quick pulse survey, and we found out that 93% of the individuals used it for food, which is what we had expected. Next one, please. Next slide, please. So there were a number of risks envisaged at inception. We were very cognizant that we were operating during a lockdown. Spread of the virus was a risk. Security considerations with large amount of cash moving was something we needed to be conscious of. And then Pakistan is a vibrant federal polity with different political factions governing different provinces. So we had to be, so one of the key things I had to do right up front was to convey that this is totally apolitical. It's being run in a rule-based manner, in a rule-based manner with technology hardwired, and that there would be no political mileage gaining. And hence everybody opted into this scheme. Next one, please. There were a number of challenges which we encountered, and since I'm already into the 8th minute, I will not go over the details. Perhaps leave it for the questions, if any. But I just wanted to convey that there were lots of issues we encountered, and we embedded real-time evaluation into the rubric of the operations, which is why we were able to address them as we went along and communicate them as we went along. Next one, please. Transparency was one of the key hallmarks of the program. This is a much earlier slide in which you can see that all the cash going out, its breakdown in terms of numbers. And if you scroll down this dashboard, you could see right down to the lowest level of subnational government, the amount of money that was going, who was benefiting, and how people were drawing it. And this really helped to inspire trust in the program. Next one, please. I think this is my last slide. I think that this has been a profoundly game-changing experience for the government, because it has made the government more agile, data-driven, and ambitious. To the extent of my ministry, it has changed the way we think and dream and plan. And we have also gained important know-how in designing and implementing a massive national program in real time in a context of complexity and uncertainty with speed, which I think is really going to help us. And given that we're very willing to share other countries as well as we move into this new normal. As was expected, it's helped us institutionalize digital ways of working and using a whole of government approach for that. And this is really going to help with the great global reimagination of social protection, which was envisaged earlier in Ehsaas, but COVID has really helped us with upscaling that. So every cloud has a silver lining, and I think that the dark cloud of COVID has really helped us in transforming the way government works, cementing a better relationship between the government and its citizens, and accelerating work towards the great global reimagination of social welfare. I thank you very much for this opportunity. Over.
Good morning, good evening. I am Cleopatra Mugeni, and I am going to be talking about some of the hidden populations during this pandemic. But before I get started, I'd like to first say thank you to the organizers of this symposium, and congratulations to Quarraisha and Salim on their award today. So at the International Center for Research on Women, we carry out applied research that looks at how to reduce the inequalities that populations suffer due to gender and due to social and cultural norms. And during this period of COVID-19, the focus really has been on protecting those that are most vulnerable, our elderly, and those with underlying conditions, as well as also protecting the health system for it to be able to respond to the needs of the infected during the pandemic. And so during that time, there have been restrictions put in place by governments. We have had stay in shelter, shelter at home restrictions. We've had curfews, like here where I am in Kenya. And so there have been a whole host of restrictions put in place to help us deal with the pandemic. But we really have not been thinking about the effect some of these restrictions will have on a large part of our population. So this is really looking at youth, the issues around SRH and GBV during the pandemic, and for us to think about how we can respond to the needs of these of young people, and also how we can adjust our response in future pandemics and future crises, so that we do not create another problem when we try to solve issues around the pandemic. So adolescents and young adults make up like 16% of the global population, and this is projected to increase by 62% in 2050. And so, as I've said, while young people were not the most vulnerable or are not the most vulnerable during this pandemic, they have been affected by the response, the public health, as well as government responses to the pandemic. We also know that for young people to thrive and for us to reap the positive impacts of the demographic dividend on our economic growth, we need to allow young people to be able to access and have good health, education, as well as employment. We also know that during adolescence, gender norms and stereotypes really firmly take hold, especially with adolescent girls facing intense pressure to conform to these gendered expectations. And we also know that gender-based discrimination can be particularly exaggerated, with girls facing greater likelihood of experiencing a range of challenges. We also know that at this stage in life, mental well-being is also key for this transition period. And young people rely on their networks of friends, of family, of schoolmates, of colleagues in the workplace to help them make a healthy transition. And we're seeing that the COVID-19 pandemic, with this social isolation, really has affected these networks. When it comes to sexual reproductive health and youth, we also know that access to contraception, abortion, post-abortion care, and also wider SRH services is essential for young adults and adolescents. And even though there has been a reduction in fertility, between 1990 and now in 2020, and an increase in contraceptive use amongst unmarried and married youth, there has only been a modest reduction in the unmet need for family planning. So we also see that SRH, very important to the health and well-being of young people, and also something that has been adversely affected by COVID-19. So these vulnerabilities that young people inherently tend to worsen during crises. So you'll find that there's increased vulnerability to gender-based violence, and we have seen cases of increased GBV reporting. Young people are also more likely to fall victim to sexual exploitation. Social harms and gender inequalities are heightened, again, because social networks are broken down, and in some parts of the world, like here in East Africa, even though there were curfews put in place and there were restrictions on groups of gatherings, we did find and we did hear stories in the news of young people still wanting to party, still gathering in groups larger than were allowed, so that they could socialize, something that they are wont to do at this age, but putting themselves at higher risk, but also trying to satisfy that need to socialize at this stage. We also have seen that safety and social support challenges affect young people because of breakdown of networks. And if young people want to access services, they may not be able to do that. And then we also see there's a loss of voice and agency. Then we also see economic shocks also affect young people, and loss of livelihoods is a really big one, especially in households. We see that young people are taking on income generating activities to support the family, and there is increased mental strain within households. And we also see an increased care burden by women and girls. So when we look at the SDGs, especially the SDG1 around no poverty, there has been this livelihood disruption. Income from low-income youth have been forced, like I said, into income-generating activities to support family survival. And we're also seeing increased cases of young women and girls engaging in transactional sex to survive. Interestingly, it's about food, it's about essentials like sanitary ware that's driving young women into engaging in transactional sex. When it comes to good health and well-being, SGD3, we see because of the access to SRH services being disrupted, we're seeing a reported increase in teenage pregnancies and unsafe abortions, as well as physical and sexual violence, because young people also don't have anywhere to turn to. And then when it comes to the mental health of young people, there have been increased self-reporting of depression. And because young people don't have access to networks, access to people to speak to, this has caused a large problem in some communities. When it comes to quality education, SGD4, we see a widened inequality gap for learners from poor, vulnerable, and marginalized households. Some of these inequalities leading to, like I've said, transactional sex, others engaging in other income-generating activities, which may not be safe. And when it comes to gender inequality, we actually already seeing data indicating that reported cases of GBV have doubled in some countries. And we know that 12 million girls marry before the age of 18 every year. And because of this disruption that has happened with young people out of school, unable to go to work, that we may actually see COVID-19 leading to an increase in child marriages in some populations. So what can we do to improve delivery of SRH and services for the youth? I think, like has been mentioned by previous speakers here, we really need to be collecting, tracking, and using gender disaggregated data to inform the response. And we need to also think about what the restrictions and what our public health responses to pandemics actually do to certain members of our populations. We need to be thinking about increasing and ring-fencing SRH and GBV funding, because we do find that some funding was diverted away from these services so that we could have financing going into the COVID-19 response. And we also saw that because of restrictions that were put in place by governments, that enforcement and adherence to GBV laws and policies may have actually broken down. Young people don't have anywhere to turn to. The safe houses may have been out of operation, and because of fear of infection, even if young people did turn to some of these services, they may have not received them. And then we also need to think about deliberate inclusion of SRH and GBV policy actions in COVID-19 response plans. One of the previous speakers spoke about adapting to more remote approaches. We are lucky at this time of social media use and internet that we can actually engage with young people more, and that is something we should be doing. And we should also be thinking about expanding social support as well as addressing harmful social norms. We also need to think about improving accountability, because while we may be doing well responding to the pandemic, we may actually have inadvertent negative impacts around young people. So that's a very quick run through of what we need to do to think about improving this response for young people to SRH and other services that are essential to them. Thank you.
Great. Well, I'm really excited to welcome all of our speakers back again for a lightning panel. This session is really going to be focusing on equitable and intersectional approaches to the Sustainable Development Goals and COVID-19. It really is my privilege to moderate this panel, particularly with Dr. Sania Nishtar, Dr. Cleopatra Mogini, Professor Abdool, Karim, and Dr. Soumya as well. As we've heard from our speakers already today and the great symposium we've had, COVID-19 has changed the world profoundly in just a few months. Over 1 million people have died, and many of the 30 million people infected will have long-term health damages from this virus. The social and economic impact of the pandemic will scar future generations, and it is far from over. The virus does not discriminate. Even presidents can be infected, but it is not an equalizer. The pandemic is deepening existing inequalities. Half the world lacks coverage for the most essential health services, and universal health coverage is a distant dream for billions. Long-standing structural, social, economic, and health disparities mean lower status social groups have more exposure to infection and lower paid, frontline jobs, and overcrowded housing. They also have worse outcomes due to their poor underlying health status. Although in most countries, men have a higher mortality rate from COVID-19, women and girls are bearing the secondary impacts of the pandemic that worsen their already weak social and economic position. At this time, however, women are much more than victims in the health emergency. Since women are 70% of the health workforce, our lives and health depend on women on the front lines and social care that they're providing to clean up this man-made disaster. We're going to be hearing from our speakers to reflect particularly on how we can have greater equity, how we can apply an intersectionality lens, and look at things from a power perspective. So I'm going to turn first to Dr. Sania Nishtar. COVID-19 has exposed deep inequalities within and between countries. Can you give us examples of how greater gender equality and reaching the most marginalized supports stronger economies and healthier societies?
Well, there's a direct relationship between economically helping those who've lost their livelihoods, for example, through cash transfers, and better macroeconomic outcomes. I mean, the more cash you pump into the economy, the more businesses it supports, the more cash circulates. I mean, if governments have a choice, underwriting big commercial entities, underwriting their losses vis-a-vis supporting, 15 or 20 million families, which is better economically. It's clearly the latter that is beneficial economically, because the money will circulate. The industrialists will probably just put the money away, or if not, take it offshore. So I think that the benefits to the economy are significant. And when we were planning Ehsaas emergency cash, we looked at a meta-analysis of the evidence, and what we found out was that the benefit of in-kind versus vouchers versus cash, the benefit to the economy is greatest with cash, lesser with voucher, and least with in-kind rations. And the risk of pilferage is, it's inverse.
Thank you, Dr. Sania. And just kind of building on that, and the multiplier effect that we see about having women really engaged formally in the economy. Similarly, what are your thoughts about women being engaged in senior leadership? A recent review that we published, Women in Global Health, shows that 85% of the COVID-19 task teams, which are over 115 around the world from 87 countries, show that 85% of them are majority men. Why don't we see women in decision-making roles in emergencies, and what impact does that have?
Is this a question for me, Rupa?
Yes, it is.
Okay, so before I answer this question, I should have mentioned in response to your previous question that 45% of the recipients of Ehsaas emergency cash were actually women. And we know very well that when women have cash in their hands, they are likely to obviate the negative coping strategies which have implications for children a lot better. Children dropping out of school, less nutritious food coming home. So clearly putting cash into the hands of women pays far more dividends. But in terms of your question about decision-making roles, we all know about the glass ceiling effect, and we all know that in the health sector at the entry level, there is perfect parity. But as you go up the ladder, it's not just the glass ceiling, it's also a leaking pipe all the way up. And you yourself have spearheaded this, the wonderful work and you continue to raise awareness. So COVID was not a time to cultivate leadership at the top. I wish it had been, but I think governments were so mired in trying to respond, trying to save lives, trying to save livelihoods, that whoever was at the table was given a leading role. But whenever a woman was at the table, I tended to see consistently that decisions were far more gender sensitive.
Thank you, Sania, and I really appreciate those insights and the case of really women's economic engagement, but also just really the hard realities of breaking the glass ceiling, as we say. I'd like to turn to Dr. Cleopatra. We know that there is a scarcity of implementation research, especially in lower middle income countries. How can researchers be rooted in real world problem solving? What can really be done to address some of those real-world problems, such as teenage pregnancies during COVID-19 lockdown?
Thank you, Rupal. I think what's needed is researchers need to understand the underlying drivers of inequity, the determinants of health that impact disease and treatment outcomes. So beyond the biology, we need to understand why certain populations are more susceptible to disease. What are the social and gender related factors that affect access to services? If it's treatment, what affects adherence to treatment? So unless you understand these underlying factors, it becomes very difficult to develop interventions that will address the issues. We also need to understand dynamics and the social factors within populations. So, and ensure that all research that's being done is participatory and engages with the target groups, because unless you are engaging with the target groups, just like was mentioned here at the top of this symposium, become more human, and help communicate your research better, understand what the target groups actually need, then you will not be able to get the results that you're hoping to get. And when it comes to issues like teenage pregnancy, realizing that a single approach is not going to work here. We may have a crisis that is happening and that we have to address, but we also need to think about what happens when we put in place certain restrictions, when we focus all of our attention on one area. Are we going to now have a teenage pregnancy crisis or a GBV crisis that will make itself more known once the focus is off COVID-19? So understanding that these other issues and problems don't go away. Even when we're in crisis mode, we need to have a part of our health system, part of our public health research is actually looking at these issues that don't go away and are actually exacerbated by the pandemic and the vulnerabilities in populations.
Great. Thank you, Dr. Cleopatra. So I'm actually going to, jump to Dr. Soumya as the chief scientist at WHO. In your experience, what role do scientists and researchers have in guiding policy and decision-making to focus on issues affecting the most marginalized and vulnerable people in society?
I think that the biggest role that scientists and researchers can play is to bring the data in front of people, in front of the policymakers. I think this has been said earlier. And the problem with most of researchers or scientists is that, including myself, is that you are focused on your area of work. That's the most important thing to you. You don't really see it in the context of everything else that's going around. You're least concerned or involved in the other drivers or levers that policymakers are using, the economics of it, the competing priorities. So I think we need to, and this is something that has to be part of our training. It's not. I got exposed to all of this very late in my career when I realized how policymaking actually happens. It's not just based on the evidence. So your job is to produce the evidence. You need to be competent at what you're doing. You also need to be, I think, empathetic and compassionate, because if you don't have that link with the communities, at least I'm talking about medical researchers here. And if you're in an ivory tower doing some research, then that's not going to go very far. So you need to have that connection. And the third, I would say, is communication. So I think competence, compassion, and communication. And again, that's not something that we're all trained. We're not all good at communication. And so sometimes you're talking at cross purposes with policymakers. So you have to understand where they're coming from, what's driving their decision making. What would be a win-win for a politician? I think Sania gave some very good examples, of doing the right thing and still getting the political mileage out of it.
Great. Thank you, Dr. Soumya. And I think there's a clear lesson there, like how do we create more win-wins, which is definitely political language, and make that part of the lingo for researchers. And so on that note, I'm really excited to both invite Professor Karim and Quarraisha, who don't need any introduction today, and really congratulations to you both and the duo team that has really shown what persistence is and how to really work on social issues that are really for the hardest to reach populations. So as I turn to you, due to the gender power imbalances, young women are often unable to negotiate condom use, insist on mutual monogamy, or convince their male partners to have an HIV test. We're also witnessing widening gender inequities in COVID-19, as we've heard earlier today. Can you share with us, as a researcher and policy advocate, when comparing the role of science in both HIV and COVID-19 epidemics, what single key issue stands out for you as you look at the response with the lens of equity? So really, what's that single issue? Which I know is hard to pick, but turning it to you, Professor.
So as I reflect on both these epidemics, I think the single issue that stands out for me is that when we are looking at solutions to these epidemics, we can't look at them in the sole lens of solving a technological problem, because most of these diseases are fundamentally spread by behavior, and that we look to behavior change for prevention. So the technologies that we are trying to do have to accompany a sense of social justice, a sense of how we're going to make them equitably available. And I think we're seeing that most clearly now in COVAX. But when we think about, Quarraisha and I, and much of our research that we'll talk about tomorrow in HIV, we were not simply trying to develop a technology. We were trying to develop a technology that empowered women to take control of their risk of HIV. And I think that as we now will be looking at new therapeutics, We're going to look at vaccines for COVID-19. It's really that same approach that we've got to be thinking about the social consequences, about equity and social justice as we think about these technological solutions.
Great. And I think, what you're talking about is really linking research to social justice using the words. And it is clear that, the work and the decades it took to get to where you are and how you have really put women at the center of empowerment has been really critical. And just sort of building on that, South Africa has been affected severely by the COVID-19 pandemic. What impacts have you seen for women and girls, and how far have women been including in really empowered, especially when it comes to decision making?
So when we look at, there have been many impacts of this epidemic on women. I'll just touch on 3 of them that have been particularly highlighted as we've been progressing over the last 6 months. And the first of that is that when we instituted the initial lockdown, we didn't anticipate and didn't foresee that we would have this drastic rise in gender-based violence. It's quite striking, actually, to see the increase in the number of cases that occurred. And now that we've got that benefit of the hindsight, we now have to look at the whole issue of how we institute our restrictions much more carefully with that kind of gendered lens. The second has been that women initially were much more heavily impacted by the high number of cases that were occurring because they predominate in our healthcare system. The majority of our healthcare providers, nurses, and pretty much all of the levels is dominated by women. And so when healthcare workers were the initial wave of infections we saw, they were largely women. And then the third, I think that we've already seen, again, from the point of view of the impacts of the interventions, is the impact on sexual and reproductive health services, the ability to access contraception, the ability to get your STD treated. All of those were compromised, not necessarily because the clinics were open. It's just that people were hesitant to go to a clinic because the risk of COVID became real, and they were concerned that they wouldn't get it. So I think we've seen all of these issues. And interestingly, I've seen the analysis being done about presidents and prime ministers who are women tended to respond better to the COVID epidemic. And it's certainly true in many of our instances. Hospitals and healthcare services run by women tended to respond better, more empathetically, and in a much more organized way. So it had many benefits to us in our response. But I think overall, as we look at the impact, we need to be very clear about carefully considering ways of mitigating the impact on the gendered aspects of the negative side of our interventions.
Great. Thank you, Professor Karim. And I'd like to turn back to Dr. Cleopatra, who's really done some immense work on what it means to look at things from a gender lens perspective. And so I'd like to ask you, gender equity in health strengthens health systems for everyone. We're hearing the term gender responsive health systems and really how to be more transformative and intersectional. Can you tell us, what does this mean to you and why is it important?
Well, it's important because we then get the greatest outcomes for patients who are seeking treatment, but also we have better outcomes and better health for the people working within the health system itself. So we really need to be thinking about gender at all levels within the system and within all activities. I think what we need to be aware of is men and women and other genders have different needs across their lifespan. So health systems need to be able to address these different needs across their lifespan. We need to give them integrated services. We need to be aware of the issues they have with accessing services, with accessing treatment, and figuring out how can we provide better access to these different populations. We also need to think about the financial burden that health systems put on households, especially low-income households. So we need to figure out financing systems that are equitable and minimize the risk of huge costs, especially at a time like this when everybody is going through economic shocks. When it comes to health professionals, we need to make sure that the health system has equitable opportunities for men and women across all cadres in the health system, because we do see, and it has been shown, that patients will be more comfortable with a health service provider who looks like them, who sounds like them, who understands the issues that they're going through. So we need to also have diversity within our health system. And also data. We need to produce data that's sex aggregated, that provides the right information about populations, and especially within our countries, we have very different populations. So we need to be able to identify the needs of each of these populations. So health systems also need to be able to identify the gender dimensions of health outcomes. So I think those really, if we look at those different factors and those different areas within the health system, then we would be building a more equitable health system. Thank you.
Great. Thank you, Dr. Cleopatra. And I want to quickly turn to Dr. Soumya just to reflect very briefly on, like, COVID-19 is a global wake-up call to build back better. What role can digital tools play, especially on addressing issues of equity and intersectionality?
Yes, I think digital tools can play a big role. And, we've seen examples mentioned today about the digital payment systems. I think in Africa, in many countries, these digital wallets have made a big difference. And I think disproportionately to women, who've been then able to control the resources. So many countries now are realizing that you need to put money in the hands of women. And in India also, there was a huge program a couple of years ago encouraging everyone to have their own bank account, because many women did not have bank accounts. And so there was this big mass movement, millions of women opened bank accounts so that they could get their social security deposits or their whatever payments they were getting directly into there. And I think there's enough work to show that once money is in the hands of women, they actually use it for the priority needs of their families. It could be food, it could be education, but very often when the money is in the hands of men, it goes in alcohol and tobacco, and there's domestic violence involved, all sorts of things. So clearly, digital tools, particularly in transfer of money into the hands of women directly, is one way. But I'm also always very concerned that our huge emphasis on digital tools and technologies could also exclude people, because there are many parts of Asia and Africa and probably Latin America as well, where internet penetration is still low. You may have phones and mobile phones in the hands of people, but not necessarily smartphones, and certainly you don't have internet access. And so sometimes we tend to think, you make it all digital, everybody's on Zoom, things are going on as normal, but that's not the case. We know also for education that millions and millions of children are not able to access online education and are really suffering. And so we need to think about, make sure that we don't exclude the same group that are always excluded when we move to digital. So we have to make some special efforts, both probably hardware and infrastructure, but also in the way we design the systems to make sure it's inclusive.
And Dr. Soumya, that's a great point to wrap us up. And, we opened with Dr. Sania giving a prime example, particularly around, the role of really economic empowerment using digital tools, and a fantastic example, but, also keeping in the equity lens and the gender lens, throughout this. So as I mentioned, this is a lightning panel, and we could talk to all of you so go for hours about the deep knowledge you have on these issues, but some key takeaway messages is that we know we need to learn as researchers and scientists and academics really to talk in a political savvy manner. We must have a social justice approach to it. There are wins, and we need to start thinking about that, but at the same time really ensure that we're hardwiring equity. COVID-19 has focused the world on health and brought greater understanding of solidarity and the centrality of health for economic prosperity. We have had time to consider what we value. We have also had time to reflect on the inequalities laid bare by the pandemic, and now it's really time to accelerate progress on the Sustainable Development Goals. It's not time to delay achievement of the development goals. This will lead to strengthening health security and global health, and it is time to speed up progress on gender equality and recognize the role women play in health, social care, and society. We know what it would mean to really have decent work, safety and dignity, fair pay and equal leadership, so women can deliver better and stronger health outcomes for everyone. So let's really use this devastating pandemic as a break in history and a chance to build back better, which means building back equal. So I want to say thank you to all of our speakers for just really having a candid conversation with us, and I turn it back to the organizers to continue the symposium. Thank you.
Thank you so much. This is a very rich presentation panel. I cannot do justice to comment on it. It's my pleasure now to introduce an expert who has traveled exceptionally well with passion the worlds of science, academia, and global health leadership, a long-standing friend of IDRC and for whom I carry warm greetings from IDRC's president. It's my pleasure to welcome Dr. Peter Piot, who's the director of Handa Professor of Global Health, London School of Hygiene and Tropical Medicine, and the 2015 John Dirks Canada Gairdner Global Health Award laureate, who will speak to us about the age of pandemics, how to prepare and how to respond. Dr. Piot, the floor is yours.
Thank you very much, Pastor, and hello everybody, and particularly greetings to Quarraisha and Salim. And I'll end by saying a few words about you, but now I'm going to go straight into my talk here. And the title of the talk is actually inspired, can I have the next slide, actually by Tony Fauci, who spoke about the era of pandemics. But when you look at the paper that he referred to that was published in Cell, a few weeks ago only, it's very clear that, pandemics, epidemics, emerging infections have always been part of our human condition since we became sedentary from becoming nomads. And this is a list, and I won't go over it, but it's fairly Americano, European-centric, but there are, these epidemics have caused millions and millions of deaths. And the last two big ones of the last century actually are the Spanish flu and of course HIV, as we could hear from Salim and Quarraisha. Can I have the next slide, please? And there is clearly an increase in the number of outbreaks, and that is something that you can see, for example, with Ebola first in Central Africa, where the dogma was that this was a Central African story, but then we had a major outbreak in 2014 in 3 West African countries. And in this year, the big outbreak in Eastern Congo, DRC, was not even fully finished, that we had already another one in in the Equateur province. Can I have the next slide? And there are some good reasons for, or bad reasons, I should say, why we are seeing more and more pandemics. And what used to be maybe a local outbreak today has a much higher risk of becoming global than ever before. And some of the factors are here on this slide. It's from the book by Jonathan Quick, but there is the population growth. When you look at the upper left corner, when the Spanish flu hit the planet, there were like 1.7 billion people and that caused 50 million deaths at least. Today, as you know, we're well over 7 billion. That increases the population pressure on nature, urbanization, so high density, populated areas, international travel, not only for pleasure and for business, but also displaced populations. Climate change is definitely playing a role, not only because of desertification, water problems, extreme weather events, which can create also epidemics. Think of waterborne or vector-borne diseases. Conflict, often, epidemics are there where there is a conflict and where there's a breakdown of of the health systems and prevention. Poverty, a continuing driving force. Deforestation, food demand. So all this together means that actually our ability to live in harmony with nature is really gone. And I'm not pleading for a return to nature and to nomadic existence, because that's just not possible at all. But I think we are at a point where not only is this causing climate change, but I think also increases the risk for pandemics. Next slide, please. And what they all have in common is that they're all zoonoses, certainly the viral ones. And be it HIV, where, the chimpanzees, where it's bats, of course, are a major reservoir and are a very intriguing, species with hundreds and hundreds of bat species, be it for Ebola or for coronaviruses. And as you see here on the left side, it is really the interaction between us humans, our behavior, the way we organize economy, the environment, and then also animals. And that's a very big, reason why we need to approach this as a One Health issue, not just look at human health. Next slide, please. And it's fascinating to see, when we come back to the epidemic of today, the pandemic, what a rich gene pool there is in terms of SARS-related coronaviruses. Some groundbreaking work that started with the 2003 SARS epidemic, trying to identify the origin and the animal species that it came from. And Tony Fauci referred to it also. But can you imagine that in just a single cave, that 11 new strains of SARS virus were identified in horseshoe bats by WHO and colleagues published in 2017. And in the same bat cave, they had actually found the human SARS coronavirus. And you can imagine how there is constant recombination, reorganization of the genome, and at some point, there is then it jumps from host. I mean, is the host shifting? Can I have the next slide? And no time to go into this, but that's a really very important element. And it is likely that humans are constantly infected with viruses coming from other animals, but in most cases, it's an abortive infection, or it's not transmitted to other humans. And all this means that we need to, most of us here are in the human health, that we really need to look at other animals than us human primates. And that animal disease surveillance is critical for this early detection and rapid response. And we need to invest in that, because it may mean, not always, but that we can anticipate what's going on. And I think the influenza surveillance systems in poultry, in birds and so on, is a good example that this is paying off, although it's not always predictable whether a particular new strain of influenza will actually become a major pandemic, an epidemic, or just cause a few infections or even a few deaths, as we've seen in the past with H1N1. Can I have the next one? With H9N1. Now, looking at the COVID-19, I won't repeat because we all have spoken about it. The one point I would like to make is that these confirmed cases represent really mostly testing activity. And it's interesting to see that it's in The Economist a few weeks ago that I found that, interesting estimates saying that, no, we're not talking about 40 million cases. That was on the 20th of a few weeks ago. No, we're talking about 600 to 700 million people who have become infected. It's huge. Although from the perspective of a virus, that means that there are still about 7 billion people who have not been infected. And so that's fantastic from the perspective of the virus. So we're really going, we have a much bigger problem than what the confirmed cases tell us as a story. Can I have the next slide? And Tony mentioned in Europe and Soumya, and we're in the middle of a resurgence. I don't think saying that this is a second wave is not really totally correct, because the virus has never been away at all. You know, it's never been gone, and because it's been suppressed thanks to the measures that also Salim described and Tony. But there is now, we're in an absolute resurgence, although the number of cases is not yet as it was in the European spring, but hospitals are getting full, and also mortality is slowly going up. The good news is that survival rate of those who are hospitalized is getting better, including if you standardize it by age. And what's also different is that the major role that young people have been playing in spreading the infection, opening of universities, holidays, but now the most vulnerable are again being infected. Next one. So this is a real crisis situation. One thing I'd like to mention is that what is clearly also is that what we call now long COVID is also going to be a major burden on the health system, besides being a burden on individuals. It's something that I experienced myself personally after an initial acute infection with hospitalization, and where oxygen saved my life. It is really the months and months of exhaustion and interstitial pneumonia and cardiac problems that I think is still underestimated what it means in terms of the impact of this epidemic. And what's interesting also is that it can happen also to people who experience a fairly mild infection initially, in young people also. And so that's a good reason to, again, to not go for, let's say, I'm going to come back to that, to a strategy based on herd immunity. And for me also, it's a reason that I'm firmly opposed against this human challenge, experiments that are in the pipeline, as long as we don't have a fully effective therapy. Next one. We're actually only at the beginning of this pandemic, I'm afraid to say, as they say in England. There will be shock waves. The economy, we know the health outcomes, and we heard food insecurity, the impact on education and so on, and a major mental health crisis. And it deepens social inequalities in a big way. Next slide. This is from the Global Pandemic Monitoring Effect. Now, I don't know in Canada, but here there's a increasing debate whether we should go for the strategy of so-called herd immunity, a term that comes actually from vaccination programs. And, and that stipulates that only a proportion of a population needs to be immune to stop an epidemic. Now, that proportion can be very high. Like for measles, we know it's like well over 90%. For other things, it may be 50%, other infections. In the case of, the infection with SARS-CoV-2, we are probably talking about 2/3 of the population, maybe 50% when you go into more specific fractions of the population. But there are so many unknowns. We don't know for how long people are immune. There may be several rounds of reinfection are needed, the duration of immunity, etc. But also what these people are, who are defending, promoting herd immunity, tend to forget that the mortality will be enormous. Herd immunity was a strategy that, that has been here for centuries, for thousands of years. But in the 21st century, we have, we have a duty for, care, and we have the means to not have the natural history of everything in health that we do, including in pandemics. Next slide, please. Now, what about the future? Being Belgian, this is from my favorite painters, René Magritte. And next slide. So where are we going with the pandemic? Of course, nobody can really tell, and I don't have my crystal ball here, but it all depends on many factors. And I'm not talking now about what a vaccine will bring, but it depends, for example, on how long immunity lasts. We could have an annual pandemic, in more or less severity. If the pandemic, if the immunity, protective immunity lasts a long time, then the pattern will be different. We can have cold season related, etc., etc. Next slide, please. And the question is really, will SARS-CoV-2 become endemic? Because this is something that we've seen in history with a number of viruses. Probably the most extreme case are retroviruses who become so endemic that they are being part of our own genome. That's the ultimate success from the virus perspective, I should say. But we also have, for HIV, I would argue that it's becoming endemic in many parts of the world, and certainly in KwaZulu-Natal, where Salim is and Quarraisha are doing such a fantastic work. So it depends now what will happen. What will happen with the virus? Mutations are always there. In which direction will they go? We don't know. The immunity, the length and so on, and the type of immunity. What we will do as societies in terms of interventions. Will there be interference, interactions between among viruses, and will there be seasonality? So all these are still open questions that are extremely important to deal with. Also, for example, and can have the next slide, when we talk about how we're going to deploy vaccines. I won't go here because over the which vaccines are in the pipeline. Next slide, because we heard it from Tony. But also that, in normal times, it takes about 10 years, in best case, to develop a vaccine between the initial, let's say, academic type of research and a product that's on the market. Next slide. This is now, for us, we have to compress this in, next slide, in a year, 18 months. And let's take the example of the Ebola vaccine, because it's one of the, the gifts of Canada to the world. In 2002, there was, and based on research that began many years before, the lab, the National Microbiology Lab in Winnipeg, already, started developing the vaccine, but it took until 2019 before it was actually licensed. And here the reason was, and this was unlicensed by Merck. Similar story with the Janssen's Ebola vaccine, where Crucel, a company in the Netherlands, started working on it in the early 2000s. And here it was typically more something a lack of market incentives than anything else. Can I have the next slide? But the good news is that at the moment, there is an incredible effort, collective effort all over the world, I would say, in terms of speeding up vaccine development, but also already thinking of, access, equitable access, like this is the hallmark of the COVAX initiative that was launched by the European Union together with the WHO, CEPI, and Gavi. And we had as a Coalition for Epidemic Preparedness Innovation, which was launched after the West Africa Ebola outbreak. And in the African Union, the Africa CDC has become very active also by launching a consortium for vaccine clinical trials. Next one. Now, will vaccines end the pandemic? I think we need to be doing here a bit of, expectation management, because it's not going to be so that one fine day early next year or whatever, that we will suddenly stop this epidemic and can go back to so-called normal life. So the questions are, will it work? For how long? Will it block transmission? Will it only prevent mortality and severe illness? I mean, which in itself will be good. The FDA has put 50% as the minimal level for effectiveness or for efficacy in clinical trials. So it's likely that the first generation will be not so perfect, but it would make a huge difference. Safety, huge concern. And, we're going to inject biological materials into billions of people, and you can't afford to take any shortcut when it comes to safety. And there will be a really need in the 6-pointer for very close, post-marketing monitoring. It's not post, but post-marketing. Will there be enough vaccines? We need to develop billions of doses. That requires billions of glass vials, billions of syringes. They're simply not there at the moment, but there's a huge effort by any and every big vaccine manufacturer, and also, by public authorities. Who will get it first? And this is going to be a big issue, both at personal level in each country, but also even political and economically, because a country that can protect their population first will have a major advantage. And will people accept it? There was another report that came out yesterday in Nature, Medicine, and showing how there's really a very high degree of skepticism. And in Europe, for example, both in Poland and France, the two layers, the majority of people said that they will not take such a vaccine. Can I have a next slide? So we need to do everything we can to make sure there's the trust. Next slide, please. Now, there's been a global health security index trying to estimate how well a country is prepared. And it's a complicated slide, but to make a long story short, the two countries that were at the top in preparedness, according to this index, were the US and the UK. And neither have done really particularly well when it came to dealing with COVID. So we missed the boat. We need really to rethink what it means, preparedness. Next slide. So here I'm one of the things I'm doing now in my free time, so-called free time, is I'm a special advisor to Ursula von der Leyen, the president of the European Commission. And in her annual State of the Union a few weeks ago, she devoted a lot of time to to this crisis, the COVID crisis, and because it is really the biggest crisis that we're dealing with in peacetime, and but also making use of a crisis is always an opportunity to reinforce structures, public health structures in Europe, build the European BARDA, and learn global lessons. And there will be a global health summit next year in Italy as part of the G20. And Europe has been very active in terms of vaccine development and access without going into vaccine nationalism. And that's through COVAX, but also dealing with advanced market commitments that will also benefit low-income countries. Next slide, please. So going to the end, some of the lessons from past epidemics are there. And some people say that this was a black swan. I don't think this is black swan. This was a purely white swan. We all saw it going. Tony Fauci, Bill Gates, myself, and others, we've given talks. Are we ready for the next pandemic? And the answer was always no. And so here, a few lessons. Certainly act soon. And here, the risk is that you will act or overact because you don't really know whether it will get out of control. We've seen it in 2009 for H1N1. But it's better to, to do it and not to take chances. Political leadership, we heard it from Salim and Quarraisha, is so important. We have too many bad and good examples. And then science, obviously, very important, but making sure that whatever is coming there as innovation can be promptly used. And that requires commitment to not only rapid review and so on, but also to equitable access and massive investments. No magic bullets. Quarraisha said it very clearly. We need combination prevention. It's for HIV or for COVID. And even when we will have a vaccine, and I'm pretty optimistic we'll have some, we will need to continue to do certain things. Social distancing and certainly mask, will still be part of our way of living. And then, if there's one lesson, and that was learned and only taken up by a few, like after the SARS epidemic, countries like Singapore and Taiwan and, Korea, South Korea, they invested massively in public health systems and societal preparedness. And that is what we need to do now for the next pandemic, because it will come and build a coalition. So all the same, lessons as Salim and Quarraisha mentioned. Next slide. Now, we have to think also about societies living with COVID-19. And because it's likely that we will have series of outbreaks, even with a vaccine, new pandemics will come up, and it will require a major change in cultural and behavioral norms. On the right upper corner, you can see how this is from the Spanish flu in Japan, where that's at the origin of masks that we're wearing when you have a cold yourself. I won't go over here, but we need to change how we live, work, travel, interact with nature. Next slide. Now, to end, for my 65th birthday, I went back to where I'd worked in 1976 in northern, was then called Zaire, Congo, to see what had happened. I had been back until 86, but no longer before, because there was a WHO meeting, there were all international meetings saying, never again, we will build a health system, we will do this and that. And what had they done for that part of, very poor part of the Congo? Absolutely nothing. You see the lab, you see the lab technician, Sukato, who was a survivor of Ebola in '76. It was really a scandal. And so I hope that the current pandemic is a wake-up call that we will massively invest in these systems. Last slide now. And this is one for good friends, Quarraisha and Salim, also on behalf of Heidi, my wife, in good memories of several meals we've had, because these are the only photos I could find was of parties and meals, but we do some work, of course. And on the right side is when Salim was elected as a Fellow of the Royal Society, which made us also proud. And I can't think of better laureates of the Gairdner Global Health Award. Thank you so much for listening to me, and many happy, healthy, and creative years to come for Quarraisha and Salim. Thank you very much.
Thank you very much, Peter. Professor Piat, that was very excellent. And thank you for wrapping up our symposium. What an excellent set of speakers and ideas that we were exposed to over the last couple hours. I'm taking away today a better understanding of the opportunities that the current health crisis presents to better build forward, as was said by several of the participants, and where there remains significant challenges still standing in our way. I also really want to acknowledge how frequently the speakers reference the messiness of human behavior to influence the outcomes we are seeing, for better or for worse. We heard how scientific and social evidence and nuances are and should be influencing actions. Didn't see an ounce of paralysis of synthesis on display today, but it does give me kind of a mixed emotions as I walk away from this set of panels. Montasser, it's been a pleasure co-hosting with you, and I will pass it over to you to close us off.
Thank you so much, Carly. Thank you very much, everyone. In terms of my take-home messages, is that sort of before COVID-19, there was a concern that maybe the SDGs will not be reached by 2030. And now this year in 2020, there is a real concern that that has become, this concern has become a serious doubt that we actually very seriously may not reach the SDGs. So our symposium today give a little glimpse of how the global health community must, as members of that community as well, we must redouble our effort to make sure there is no going back on previous gains, and in fact to move forward and upward. And to reaffirm the role of science and the role of women in science to contribute to moving humanity from towards a better and healthier future. Thank you all for being here today as participants. Thank you for our fantastic speakers and to all the wonderful partners that have put this symposium together. We sincerely hope that you stay safe and keep well, and we'll see you again. As a final announcement, we encourage you all to follow Gairdner on social media and to visit www.gairdner.org to sign up for their newsletter. And join Gairdner again tomorrow and Friday for the 2020 Laureate Lectures. Registration is available on the Gairdner website to hear the very best in biomedicine, global health, and scientific leadership. Take care, stay safe, and we look forward to seeing you again in future events. Goodbye.